triple coagulation, while they recommend in the case of low bleeding risk to go for complete 12 months of dual antithrombotic therapy, while in the only 6 months is recommended in high risk of bleeding. After that, both patients would go with single oral anticoagulants. The most recent guidelines of the AHA for atrial fibrillation, they recommend the use of dual antithrombotic therapy, including the B2Y12 and warren over the use of triple antithrombotic therapy. They also recommend the use of direct oral anticoagulant rivaroxaban, 15 milligram with the B2Y12, and the dabigatran 150 milligram plus B2Y12 over the use of triple antithrombotic therapy. If the triple antithrombotic therapy use is a must, then they recommend the duration of 4 to 6 weeks. Okay. Now, the current evidence supporting the use of dual versus triple antithrombotic therapy can be divided to post-discharge studies and long-term studies. The post-discharge studies include the WOOST SR triple trial, Pioneer Redual, Augustus, and Interest AF. After that, three meta-analysis was done 2018, 2019, and 2020. For the long-term therapy studies, the oral anticoagulants alone trial and the AFIRE trial also was done. Now, I'll start first with the post-discharge studies. I will give a quick summary of the previously mentioned trials. Now, first of all, the WOOST trial, they compare both triple antithrombotic therapy with aspirin, clopidogrel, and warfarin versus the clopidogrel plus the B2Y12, clopidogrel specifically, and they found significant reduction in the bleeding risk when compared with the dual antithrombotic therapy versus triple antithrombotic therapy without a statistically significant difference in terms of the MI, stroke, and stent thrombosis. While on the other hand, the SR triple trial, they compared the 6 weeks duration versus 6 months duration in the patients using triple antithrombotic therapy with aspirin, clopidogrel, and warfarin, and they found there was no statistically significant difference in terms of both death, MI, stent thrombosis, stroke, and risk of TME major bleeding risk. The Pioneer AF trial, on the other hand, they compared the rivaroxaban 15 milligram plus the B2Y12 as dual antithrombotic therapy and compared to the rivaroxaban 2.5 BID with dual antiplatelet therapy versus the warfarin plus dual antiplatelet therapy. They found that the lower risk of bleeding was in the rivaroxaban dual antithrombotic therapy group with the single B2Y12, the rivaroxaban group, and the highest bleeding risk was with the warfarin group. In the other hand, the major adverse cardiovascular events and the stent thrombosis was similar in the three groups. The Redual trial, they compared the dabigatran 110 milligram and 150 milligram plus B2Y12 with versus the use of triple antithrombotic therapy of warfarin, B2Y12, and aspirin, and they found that the dual antithrombotic therapy with dabigatran 110 have a lowest bleeding risk, followed by the 150 plus B2Y12, and the highest bleeding risk was in the triple antithrombotic therapy with warfarin, and without significant difference in the thromboembolic events between the three groups. Augustus trial, it was 2x2 factorial trial. They compared the rivaroxaban dual antithrombotic therapy versus the VKA dual antithrombotic therapy with B2Y12 with or without aspirin. So they add aspirin to both groups versus placebo. And they found that the lowest bleeding risk was the ibexaban 5 milligram plus the B2Y12 in compared to the VKA group. The addition of aspirin was associated with higher risk of bleeding without benefit in terms of ischemia, hospitalization, and death. The ibexaban also showed, versus the VKA, showed lower risk of death and hospitalization compared to the VKA dual antithrombotic therapy group. The last trial was the INTRUST-AF trial. They compared the edoxaban 60 milligram plus B2Y12 versus the triple antithrombotic therapy. Lower bleeding risk was seen in the edoxaban plus clopidogrel versus the triple antithrombotic therapy group, without a significant difference in the cardiovascular death, MI, stroke, and definite stent thrombosis. Now, the first these meta-analysis, they compared the previously, included the previously mentioned trials, and they showed there's no different. I will show you the slide. These are the included studies, and these are the results. You can see that there is no significant difference between the mortality, major bleeding. Major bleeding actually was in favor of the dual antithrombotic therapy group, while the myocardial infarction and stent thrombosis, there was no statistically significant difference, although it was slightly to the side of the triple antithrombotic therapy. When they analyzed only the direct oral anticoagulant studies, they include the Augustus Redual Bioneer, but not the INTRUST-AF. The results was almost the same, in favor of in case of the death and bleeding. Also the MI, also in case of stent thrombosis, it was almost the same results without significant difference between the group. While in the last one, systemic review and meta-analysis, this study actually, it's very important to know, because it showed the same results regarding the bleeding, and no difference also from this point of view. But on the other hand, this benefit of bleeding reduction was counterbalanced by the increase of the stent thrombosis. The studies included here, it's all the previously mentioned with the DOAC. I mean the Augustus, the INTRUST-AF, also the Bioneer, the Redual, all included. All the direct oral anticoagulants studies included in this meta-analysis. As you can see here, this is a summary of all results. If you go in details, you'll find results for each outcome. But as a summary, you can see here the bleeding was in favor of the dual, while the stent thrombosis especially was in favor of triple antithrombotic therapy. Okay, now for the long-term studies, oral anticoagulants alone trial, they compare the use of single oral anticoagulants plus single antiplatelets versus the use of single oral anticoagulant in patient post PCI with atrial fibrillation more than 12 months. In this trial, actually, they failed to prove the non-inferiority, because this trial was underpowered by the sample size, because the terminating the enrollment, they were targeting like a 2,000 patient within 12 months, but they ended up with 600 patients with 38 months. So this result was, they failed to prove the non-inferiority, while on the other hand, the AFIRE trial actually succeeded to prove that rivaroxaban 15 milligram versus rivaroxaban with antiplatelet after the first 12 months, it was shown superiority in terms of bleeding, while non-inferiority in terms of ischemia. Now, how we can bring this evidence to practice? Now, from what we have mentioned before, before you start to use the direct oral anticoagulants with the antiplatelets, you have to assess your patient's risk. Is the patient have higher risk of bleeding or high risk of thrombosis or ischemia? Then the direct oral anticoagulants should be considered over the use of warfarin. If you consider to use warfarin for any contraindication, you have to decrease the target INR to 2 to 2.5. For antiplatelet therapy, it's recommended to use aspirin with B2Y12 in form of clopidogrel or ticagrelor as alternative. On the other hand, avoid any other medication that would increase the rest of the patient's risk of bleeding, such as non-steroidal. Consider proton pump inhibitor to prevent the risk of, to minimize the risk of bleeding. For the duration, all the patients with, this is the most important slide actually, in all patients pre-PCI, all the patients should be considered to be on triple antithrombotic therapy. Now, after the PCI is done, then we'll check the patient's risk. If If this patient have a higher risk of ischemia compared to his risk of bleeding, then 1 month therapy of triple antithrombotic therapy should be considered, and to complete the 12 months with the dual antithrombotic therapy of oral anticoagulant and single antiplatelet. Single oral anticoagulant should be considered after the first 12 months. Now, on the other hand, if the patient have a high risk of bleeding, then you should consider the use of triple antithrombotic therapy pre-PCI with a dual antithrombotic therapy of oral anticoagulant plus single antiplatelets in the first 6 months. After the first 6 months, we should go with single oral anticoagulants. Thank you very much.
السلام عليكم مرة أخرى. في تحديد عن أمراض القلب مهم جدا تغير في البراكتس على مستوى العالم، وهو دخول الانترست على خط الهارت فيلير و ريبليسمنت للإيز انهبيتورز بانترستو. الدكتور دمرداش اليوم أحمد دمرداش consultant cardiology جامعة الملك سعود، assistant consultant. We'll talk about this important issue, and I hope we will have a brief about our practice currently according to the
Assalamu alaikum. Good morning all. First of all, I would like to thank the organizers of the conference and the scientific committee for such outstanding scientific program, outstanding speakers. We've learned a lot, and I think we'll continue to learn until the end of this day. The whole idea about this topic is how, like we have new agents, we have new drugs, but the question always comes up, is new stuff was better than old stuff? That's the first question. The second question is always that switch. Do we have any evidence on how we should re-switch? Is it appropriate? Is it not appropriate? Does it fit everyone? So to start off, I don't have any conflict of interest to disclose, and I have three major points that I'm going to discuss over these 20 minutes. First of all, I'm going to have a quick overview of ARNI. ARNI is a new mode or new pharmacological group. How does it affect the progression of heart failure? And then we're going to look at quick highlights from the outcomes of the paradigm trial. Maybe there's a nice balance from the scientific committee between my talk and Dr. Sultan's talk. He has multiple studies that he had shown, more than 12 studies. Mine, I don't have that much evidence, all based primarily on the paradigm trial. And then we're going to briefly discuss the conversion from ACE inhibitors to Entresto, and I think this is going to be more fruitful discussion maybe after the presentation and looking at that evidence. Okay. So just a brief history on the pharmacotherapy of heart failure medications. We've known that back in the 1990s, that's when the initial benefits of pharmacotherapy in heart failure started to show up. That's when we saw, or they saw, the ACE inhibitors show the survival benefits, the decreased hospitalization, and moving forward, what's happening in practices or clinical trials, it has been an add-on. So we have ACE inhibitors, they're good. Let's add beta blockers to them. Let's see how the outcomes are coming. And they've become, continue to do this up to the 2005, when they also introduced the melanocorticoid receptor inhibitors like spironolactone. The addition of all these medications showed survival benefits and also decreased hospitalization. That's why they called it the guideline-directed medical therapy or the disease-modifying therapies. But you look back in the late 2014, in September 2014, that's when the paradigm trial was published. And that was the introduction of the new pharmacological group, the ARNI, the angiotensin receptor neprilysin inhibitors, after a gap of almost 10 years from the last studies in 2005. And it's not only introducing a new drug to the market, it's also introducing a new pharmacological group that can benefit and affect the heart failure progression in a different way. So starting before going to the interest to the paradigm trial, let's look at what they found almost with the guideline-directed medical therapy. So if you can see on the slide, it shows you the angiotensin receptor antagonists, ACE inhibitors, beta blockers, and melanocorticoid inhibitors. And you can see how much the percentage of mortality reduction you can see with each one of them. You can see on this slide that the modest reduction you can see by solely blocking the RAS system using ACE or ARB. Once you look at the sympathetic nervous system blockage by beta blockers, the reduction in mortality increases, and also with melanocorticoid receptors as well. Just keep in mind that all these studies, they were add-on in the backbone of the ACE inhibitors. Some studies have been piloted to assess the outcomes without the RAS inhibition, but most of these in addition to the RAS inhibition as well. This is the 2013 guidelines and showing you the what do they recommend. Basically, the recommendations for heart failure is pretty simple. Any patients with heart failure with reduced ejection fraction should be on ACE or ARB plus beta blocker. And then what's happening with that patient, that's when we start adding new medications. Patient is symptomatic, have volume overload, add Lasix. A patient has persistent symptoms and African American, or sometimes just patient giving you a hard time to manage, that's when we add hydralazine and nitrates. And then we have the updated recommendation with symptomatic patients with New York Heart Association from 2 to 4, with normal potassium and normal renal function above creatinine kinase of 30. That's when we add spironolactone and ifluralone as well. So as you see, until now, interest did not show on the map, and where would it fit in this scheme? That's the question. So that's the introduction of the paradigm trial. The paradigm trial is the angiotensin neprilysin inhibition versus enalapril in heart failure patients with reduced ejection fraction. There's one point to keep in mind when you think about Entresto and look at this trial. All the previous trials, with no exceptions, they compared the new addition to a control of a placebo. This is the first trial in heart failure that compared an active drug to an active drug. So the drug is sacubitril valsartan compared to enalapril. It's not placebo. And that's what gave it the outstanding place out of one study to make it to the guidelines. So quickly just looking at what is this group of ARNI, what are they adding to us? This is simply in heart failure patients. The red pathway is the RAS system, and that's something that we do not want. The green pathway is what happens also in heart failure, but it's something good and we would like to. So basically the RAS system activation, it activates the angiotensin II. The reason why it happens is the body is trying to help. It's not trying to do any harm. The cardiac output is going down, ejection fraction is down, the body doesn't know what's going on. They think it might be hypovolemia, so I don't have enough fluid. You know what, just back up fluid. That's how we have fluid accumulation. It doesn't know what's going on. It thinks that the perfusion is low because of the blood pressure. It's due to vasoconstriction. So all these things are happening through the angiotensin system. So you get vasoconstriction, increasing blood pressure, and the sympathetic tone. On the other hand, we have receptors in the body that senses when the heart gets stretched. and that's the natriuretic peptides. And it's basically a quick communication between the heart and the kidneys, get this fluid out by kicking the sodium outside of the body. And that's something that we need. So BMP, the natriuretic peptides, not only have natriuretic and diuretic effect, it also has vasodilation effect as well to dilate the blood vessels. So what we really want to is just block that red pathway, and that's why we have valsartan in the combination. And then we have sacubitril, which is a prodrug, gets activated, and what it does, it inhibits neprilysin. Neprilysin breaks down the BMP. I want this BMP in the body. I want the vasodilation. One big thing is, so once we keep it, I'm going to have more from the green. The other thing is, one of the molecules that gets broken down by neprilysin is angiotensin 2. So by blocking neprilysin, you increase angiotensin 2 in the body as well. That's why you do need RAS inhibition with valsartan as well. So let's see, Z696 is interesting, but in clinical trials, before they name the medications, you have all these codes. So diving into the clinical trial, so who was included in this study? Again, as I told you, we don't have a lot of evidence. This is the only trial that has been published, clinical trial, that has published comparing interest to an ACE inhibitor. So we don't have much information. So who did they include? They include adult patients, symptomatic heart failure. So they have New York Heart Association class of 2 to 4, with BNP depending on the hospitalization time and the symptoms of the patient. One of the most important things is patients were, before enrollment, stable on 4 weeks of the medication. So they were on ACE and beta blockers, ACE or ARB beta blockers, 4 weeks before the medication, also the enrollment of the study. And the dose of interest of the ACE inhibitors had to be 10 milligrams of enalapril or more. The excluded patients who had symptomatic hypertension, systolic blood pressure less than 100, and high potassium levels, and GFR less than 30. The reason why is because the sacubitril portion of the combination has good effect on the blood pressure, so it does drop the blood pressure. Another point you have to keep in mind is the renal function was not mentioned or adjusted based on creatinine clearance. That's what we get used to in adjusting medications, is the GFR. And most importantly, angioedema. So this is the design of the study. So what did they do? The design of the study was a safe design. They had to go through multiple checkpoints. This is good for safety of the patients, but not really good for generalizability of the study. So what they did, basically, every single patient who was enrolled in the study received 10 milligrams of enalapril twice a day, that's the maximum dose, for 2 weeks. Whoever tolerated this, they had a 1-day washout, and then everyone got half dose of interest of 100 milligrams BID for 1 to 2 weeks. Whoever tolerated this, they moved up to full dose for 2 to 4 weeks. And then whoever just passed all these without any side effects, without angioedema, without any problems, and tolerated them, they randomized the patients to either be interest group at full dose or enalapril. If you look at the patients, it was 10,500 in the first phase and 8,400 in the second phase. We have almost 1,400 patients that did not make it from the first phase. They had multiple secondary outcomes, but the primary outcome was a composite of death from cardiovascular disease and the first hospitalization for heart failure. Again, baseline characteristics, all these informations are important because once you apply this to your patients to answer the question of this presentation, we have to rely on these. So if you look at the average age, it's almost 64. 64 is almost 10 years lower than the average patient population in the heart failure registries. If you look at the diversion of the patients, 66% were white, and then the minority were 5.1% were black patients, 18% were Asians. Very interesting point here, there's a study just published last month on the use of interest on African Americans, and it did not show the benefit seen in interest. That's based on the registries. That's a big question mark, because if it's affecting their patients, how genetically, how is it affecting our patients too in Saudi Arabia? If you look at the clinical features of these patients, ejection fraction was around 30, hospitalization was 60%. I want to point out the hypertension. So these patients, 70% of the patients were hypertensive patients. And if you look at the baseline of their systolic blood pressure is 120 hypertensive patients. and heart rate is of 70 and serum creatinine of 1.13. This is typically very healthy heart failure patient. However, taking care of heart failure patient, this is not a scenario you can see. So keep that in mind, because this is the only study, again, that you can extrapolate the information from it to our patients. Again, if you look at the GDMT, 93% of the patients were beta blockers, so that's pretty good. Aldosterone was almost 55%, and 80% were on diuretics. This is the primary outcome. So the primary outcome was consistent throughout, the composite of both cardiac death from cardiac disease or cardiovascular reasons, or also hospitalization was reduced by 20%. When they broke them down, the composite endpoints also was 20%. And the follow-up period was 27 months. In terms of adverse effects that were pre-specified, the old favorite interest over enalapril. So enalapril had more cough, had more serum creatinine increase, has more potassium. But again, the biggest problem with interest is blood pressure. This is very important once we get to apply to our patients, especially patients with New York Heart Association class 3, because these patients usually have soft blood pressure. You go in, you give them this medication, you drop it further, you're affecting now the MAP, the perfusion, and you get the patient to acute decompensation because of Entresto. So just to highlight some limitation of the study is, as I mentioned, the lack of diversity. The majority were white patients, and again, the study has been from the registry in African Americans and did not show. So I'm not sure if it's consistent throughout everyone that Entresto is superior to ACE inhibitors. The problem is, and this is one of the biggest issues, if you look at the FDA and the package insert, there is a lot of recommendations that were not even in the study. So in the study, everyone received enalapril, everyone's received Entresto, and then they got randomized. In the package insert, they have recommendations for naive patients who never received ACE or ARB, patients who never received Entresto, and they have adjustments on the doses. And we're going to discuss this later on. So, and this section is basically more as a discussion versus really presenting data, because there is no data. That's the question that was assigned for this topic is, so if we have a patient that is on ACE or ARB and they are reasonably stable, so the patient is fine, no symptoms, nothing, they are stable, should we switch these patients to ARBs? Rule of thumb in clinical practice, but sometimes you have to tweak this, is if the patient is doing well, don't change anything, they are doing good. And we've seen this with the digoxin in heart failure patients, just leave it on board. But when you see that this medication is affecting the progression of the disease, maybe it's worth giving a shot to some patients. But do we know who these patients are? So what I did, I just pulled two of the major the guidelines, the European guidelines and the American guidelines, and to see what they do recommend for the use of ARNI. So basically, this is the American guidelines. This is the 2017 update after the introduction of the paradigm trial. And they don't give you much information. They say you can start for the RAS inhibition, ACE, ARNI, or ARBs, doesn't matter. But if you go a little bit and look at the specification, they say in patients with chronic symptomatic heart failure, so the patient has to have symptoms. If the patient doesn't have symptoms, then they should not be switched to ARNI. They can be replaced by, the ACE or ARB can be replaced by ARNI. There's two major contraindications. If the patient received ACE, you cannot give it within 36 hours. Also, the other contraindication is if the patient has angioedema. This medication is notorious for causing angioedema. This is just to show you where the guidelines put ARNI in the red boxes. None of the guidelines recommend the initiation of any of the Entresto or the ARNIs upfront. You can ACE or ARB, beta blockers, and then if you need an addition. So for example, the American guideline says if the patient is on adequate doses of beta blockers and ACE and still have symptoms, that's when you stop ACE or ARB and add the ARNI. The European guidelines, what they do is they say if the patient is symptomatic, go first with aldosterone antagonist. So mineralocorticoid receptor antagonist, increase the dose. If the patient is still symptomatic, that's when you add the ARNI. So again, there's no clear recommendations. They don't tell you exactly what to do. So I'm going back to who's the ideal patient for Entresto. The ideal patient is exactly the patient who, the patient population or the patient who has characteristics similar to the ones in the clinical trial, the paradigm trial. So I highlighted the ones that we really do in clinical practice. BMP, there's no interaction between it and the outcome, so that's why no one does it. The patient has to be at least with New York Heart Association of 2, ejection fraction less than 40, and has to have been on ACE or ARB for 4 weeks and stable doses before switching. The patient blood pressure is very important, so they have to have a blood pressure above 100, and the potassium level within normal range, and no history of angioedema, along with GFR. Just want to highlight that patients with GFR less than 30 were excluded from the trial. You're going to see in a minute the package insert, they have recommendations for less than 30. So the question back in this study is, what if the patient is stable on ACE or ARB? What should we do? That's the same thing. If the patient is stable, that's fine. Just remove out the symptomatic part and then assess, does the patient have adequate blood pressure? Does the patient have, or can tolerate the adverse effects of this medication? Again, if the patient is taking ACE, you have to have 36 hours of gap between the initiation of RD and the last dose of the ACE inhibitors. This is the package insert. So this is very nice recommendations from the package insert. I'll tell you, like, almost 60% of what on this slide was not in the clinical trial. So for example, if you look at the first section, if the patient is taking an ACE, they give you a 36-hour window of washout. The washout in the clinical trial was 24 hours, was not 36 hours anyways. The second thing is they give recommendations on patients who are not receiving ACE or ARB. This was not even mentioned in the study or the protocol. And now they have recommendations with giving half dose and then doubling the dose. Just keep in mind, if the patient is taking an ACE, that's when you need a 36-hour wash. If the patient is taking any of the ARBs, you don't need it. You can just give the Entresto on the second dose. Here in the last 2 boxes, you can see severe renal impairment. Patients with severe renal impairment with GFR less than 30, they did not say contraindication. They gave them the low dose of Entresto. The problem is, the dose that was studied in the paradigm trial is the full dose at 200. We don't know that, is it dose specific, the outcome as we saw with all the ACE inhibitors and beta blockers or not. So it's not safe to go with these recommendations, although the FDA approved it this way. So in clinical practice, what do you really do? Again, I did not mention any studies except the paradigm trial because there is nothing else out there that we can rely on, except of some registries outcomes. So the first thing is adverse effects. Remember, one of the biggest and most important goals in heart failure is reaching target doses. So I need to reach the target dose that showed the benefit. I need to add the medications. It's not only ACE, it's not only beta blocker, it's not only mineralocorticoid receptor antagonists, it's all of them together. So I need to have some room to move with less side effects, and most importantly, the blood pressure. I need some room of the blood pressure to be able to add new medications. So that's why there is some recommendation tells you that if a patient has soft blood pressure, that's a majority of heart failure patients. You do have low sodium, low blood pressure. That's initially do not start ARB. Go ahead with ACE and ARB and see how they're doing, and then you can switch. The age gender, again, as I mentioned, the age group was almost 64. That's not representative of the patient population. Patients above 65 were 1.4% of the study, and that's it. And it was not statistically significant finding between the primary outcome. Above 75 were only 18.6%. Renal function is very important because once you start harming the kidneys, that's when you get yourself into the cardiorenal and put the patient back to acute events. The price so far, I don't think this is the price from the Saudi FDA. It costs almost 634 riyals per month and 7,600 per year. I think so far most of the patients, they do receive it in governmental hospitals. There is no cost-effective study so far about how the outcomes in Saudi Arabia and go with the price. However, in the United States, we think the price is cost-effective if it was dropped by 17%. So it's not that far from the market price. This is my last slide. I think we can discuss more in the discussion panel. So just to summarize, that Entresto has superiority over enalapril in general in heart failure with reduced ejection fraction. It was studied in heart failure with preserved ejection fraction in the paradigm trial and did not show any benefits. Some of the limitations, the big limitations of the trial is the generalizability of it. But we have to keep an eye on the adverse effects, the blood pressure, the age, renal function, the price. Unfortunately, the presentation of the study, the patient population in the paradigm trial does not represent the heart failure population, plus does not represents the diversity of the patients. Again, just one take-home message: not everyone on ACE or ARB should be switched to ARNI. It's not always better. We had a patient; she was doing pretty good. She was almost 68. She was on digoxin, ACE, beta blocker, and diuretics. She was doing fine. When she came and saw the physician, he wanted to introduce Entresto. He did, and in 2 weeks, she started having more hospitalization. It should be the opposite. And the reason why she had soft blood pressures, the kidneys were okay, but soft blood pressure. Later on, she had to be on inotropes, and she had to be hospitalized for almost a month. And the patient was from stable patient, only on inotropes, getting back to being stable. The patient had to be listed on transplant, and then the patient had LVAD implementation in King Faisal Specialty Hospital, but she did not make it for 2 days. The only reason was inappropriate. From my opinion, I think it was an inappropriate initiation of Entresto. The patient was stable. That's why initially I said, the patient is doing well, doing good, do not change medication in general. And by that, I would like to thank you all for your time. I'll be happy to answer any questions. Thank you.
السلام عليكم. في أحد عنده أسئلة؟ الدكاترة؟ أي أسئلة؟
Thank you very much for the invitation for very nice and interesting presentations. Now, Dr. Demirtaş, I could sense, from your words and your recommendation, that you're not in favor for the shift for to Entresto. Now, but yes, the evidence is fair, as you said, but when we look at that, there's a survival benefit at the end. Now, and let me just go back to the era of when the beta blockers were almost contraindicated in patients with heart failure, and we perceive theoretically that we are harming the patient if we introduce the beta blocker. Patients, even when they start the beta blocker, as you are more expert in that, they might do worse at the beginning. Then after that, we can see the survival benefits. Now, would that apply for the same thing for Entresto? I mean, if the patient had a sort of mild hypertension, then after that, if we look for the long-term outcomes, would that change your vision? Because you are the expert here among us in this field.
Thank you. This is an excellent question. I agree with you. I was planning to mention that point, that the practice in heart failure changed. If you look like 25 years ago, beta blockers were contraindicated in heart failure because they thought about increasing the contractility, and that's why we cannot use them. And then they figured out the link with the sympathetic nervous system, and that's how it works. The calcium channel blockers are still contraindicated, but not the beta blockers. I kind of not favoring using the Entresto, I am with, but the appropriate use is the key. You know, the problem is when you have a new drug, it's like having someone new in the game. It's about reputation. If the drug is misused, you're going to have, and a good example is Vibraline. Vibraline is a good drug that you can use, but it was pulled from the market because it was inappropriately used. Same thing with Entresto. If it was inappropriately used, then you're not going to get the benefit of talking about it. These increase survival and decrease hospitalization. The side effects of Entresto weans off in 14 days, by the way. So even increase in potassium levels, sometimes renal dysfunction, it goes away. The thing is, the majority of patients, we can start Entresto appropriately in them if it's started appropriately. But some patients in stage, like stage, let's say class 4 patients. Class 4 patients were included in the study, but were minorities. And these are patients, like the example I gave you, easily to be tipped off. The problem is, if the patient is starting off with a low blood pressure, then we know that the map is not that good. And the patients with heart failure either have volume overload or the perfusion problem. You are tipping off the patient by giving Entresto at that point by dropping down the blood pressure. The thing is, even though the other part of it, if you give Entresto, you drop down the blood pressure, giving you minimum room to add more beta blockers, to add, go up on the dose of the beta blockers, go up on the melanocorticoid, if you want to say as well. But again, after the 14 days, and this is a very, very interesting point as well, the increase in potassium levels with the melanocorticoid inhibitors is mitigated by Entresto up to 14 days. So it goes up and then it goes down because of Entresto, because of the diuretic effect it has and all the vasodilation and the benefits it gets. So I'm not against the use of Entresto, I am with it, but I want it to be done right, and that's why in our institution we have only 2 physicians that they can order it, and they have to follow specific checklist. Okay, does the patient have this? Does the patient have this? We still only recommend it in patients who are symptomatic, so neuroheart association of 2 or more. Some physicians, one of these 2, he has the practice unit in an outpatient as a trial for now. So a patient comes in the outpatient clinic and he's stable. He switches. It's not new initiation, he switches. And another study that has been published very soon on Entresto is in patients who are hospitalized with acutely compensated heart failure, and then they are now hemodynamically stable, should we start Entresto before discharge? Because there's another paradigm trial, that's the Pioneer trial. And they figured out that there's a benefit in early initiation of Entresto. So maybe we can see this. But once we have more, I think we need to have more experience with it. We have something really good. We don't want to use it that in the wrong way and then lose the shine of it.
في سؤال ثاني؟
شكل واحد
شكرا متحدثين الافاضل. الاستاذ الدكتور محمد الشماوي تكريم المتحدثين. طبعا إدارة الجلسة الدكتور عبد الله خربوش. دكتور عبد الله تفضل. الدكتور سلطان الردادي. الدكتور أحمد المرداش. نبدأ الجلسة الثانية بكاس الدكتور أبراف ثابت. تفضل دكتور.
طيب بسم الله الرحمن الرحيم، السلام عليكم ورحمة الله وبركاته. نبدأ هذه الجلسة اللي هي تكون مختصة بالانتيفايرال ثيرابي. حيكون عندنا 3 متحدثين. هنبدأ بأول عرض حتقدمها هو سعادة الدكتورة وفاء الفهد. Dr. Wafa is a consultant infectious diseases clinical pharmacist, and she's also the head of pharmacy training unit in Prince Sultan Military City in Riyadh. She's going to present to us challenges in the management of co-infection of HIV, co-infection of TB in HIV patients. So, Dr. Wafa.
Thank you, Dr. Abrar. Assalamu alaikum. Good morning, everybody. First of all, I want to thank the organizing committee to invite me to participate in this conference. So today, inshallah, we'll talk about the challenges in management of tuberculosis co-infected with HIV. So starting with the fact, according to the WHO, we have different challenges, starting with increased mortality rate of HIV/TB co-infected. About 1/3 of AIDS deaths due to TB, and around 44% of all HIV TB patients, they didn't receive care. Either the shortage of medication worldwide, or nobody supplied the treatment for these HIV patients. And actually, according to the WHO, reported only 15 over 30 of the countries, they reported TB prevention in HIV patients. And other countries, they didn't report regarding to the TB prevention and HIV patients. Okay. The WHO, they are working to decrease tuberculosis mortality rate from 15% to 6.5 by 2025. By implementing the TB prevention treatment worldwide. In Saudi Arabia, actually, we start to report to the WHO regarding to our cases of HIV and tuberculosis cases. The total TB incidence rate is about 10. While HIV/TB co-infected, the rate is low, it's about 0.14. The best thing, which is the mortality rate of HIV/TB, it's about 0.02. While the relapse rate of tuberculosis that reported in 2018, actually we have about 31 case relapse TB. But again, the good things, the successful treatment of tuberculosis and even tuberculosis with HIV co-infected, it's high, it's above 90% in Saudi Arabia. So why the management of HIV/TB co-infected is complicated? Actually, the first reason, which is the diagnosis or difficult diagnosis of tuberculosis, especially in HIV patients. So this reason, when we start the patient with antiretroviral and the patient have a TB but it's not diagnosed, it might increase the mortality rates in such cases. And the other reason, which is the complex interaction between anti-tuberculosis and antiretroviral treatment. And the toxicity that's shared between anti-tuberculosis and antiretroviral. The other reason, which is the spread of multi-drug resistant and extensive drug resistance of tuberculosis in HIV patients, it will complicate the treatment of HIV patients. So as we know, there is the clear guidelines, even national and international guidelines to manage to manage the HIV patient and also to manage the tuberculosis. So when we go to the overview of management of HIV, it's clear to start to patients on 2-nucleoside reverse transcriptase inhibitor together with either integrase inhibitor or non-nucleotide reverse transcriptase inhibitor, or we can use the protease inhibitor. This is regardless to the comorbidities or co-infection of the patient. So XMFO guidelines, they mention we can start the best treatment, which is ordered alphabetical, starting either with bictegravir, with Descovy or tenofovir, or we can use dolutegravir with abacavir and lamivudine, or we can use dolutegravir with Descovy or Truvada, and also they offer we can use raltegravir plus Descovy or Truvada. So for management of tuberculosis with HIV, we can say it's simple to manage HIV with tuberculosis sensitive strain. With the start with first line anti-tuberculosis together with antiretroviral that have less side effect and less drug interaction with anti-tuberculosis. For example, here for drug-sensitive tuberculosis, we can start with first-line rifampicin, isoniazid, ethambutol, pyrazinamide in the initiation phase. With continuation phase, we'll start rifampicin with isoniazid. So when we use antiretroviral, we have only to check the drug-drug interaction with the rifamycin group. For example, when we have to start raltegravir, so it's better to increase the dose, or it's recommended to increase the dose from 400 BD to 800 BD. Same thing with dolutegravir. While when we have to use the other, we have to check the interaction between or some antiretroviral is contraindicated to be used, and we will talk about this one later. If we have resistant tuberculosis, so we have to check, is it resistant to the first line or first line, especially isoniazid rifampicin, or is it resistance to multi-drug resistance or extensive drug resistance? It's better to determine the duration. So for example, if the patient considered to have isoniazid resistance only, so we have to switch from isoniazid to moxifloxacin with same duration total of 6 months. But if the patient have resistance to the rifampicin, so we have to replace and to extend the duration of anti-tuberculosis because rifampicin is a cornerstone treatment of anti-tuberculosis. And if the patient have more than resistance to more than anti-tuberculosis, we have to start second and third line of anti-tuberculosis. The patient should receive 5 medication instead of 3 or 4. Starting with quinolones, we can use either levofloxacin or moxifloxacin. Then we have to start with bedaquiline and linezolid, and clofazimine and cycloserine. If the patient cannot receive these 5 medication, we can replace with IV aminoglycoside, like either amikacin or streptomycin. In case of the patient, we'll treat it as outpatient and no need to keep the patient in hospital, so we can switch to the oral medication like dilamide or pyrazinamide or ethambutol. The recent guideline, they didn't recommend to use capromycin and kanamycin, also amoxicillin, clavulanic acid, and azithromycin, clarithromycin in management of extensive tuberculosis. So we have challenges when we start the patient on antiretroviral and tuberculosis, and we have to consider some point when we start the patient to treat it both. First of all, we have to determine when we have to start antiretroviral in tuberculosis patients. Of course, to avoid the IRIS, which is immunoreconstituted inflammatory syndrome, which cause a high mortality in HIV patients and infected with the TB. Same thing, we have to check drug-drug interaction, especially with multi-drug resistant tuberculosis, and the toxicity that shared between between antiretroviral and tuberculosis, the second line. And of course, the difficult when we treat the patient with TB with drug resistance plus HIV. So, when we have to start antiretroviral after initiation of tuberculosis, actually we have to take in consideration the CD4 count for such patients. So, if the patient have CD4 count less than 50, so it's better to start the antiretroviral after 2 weeks of initiation of anti-tuberculosis. The studies show there is it's better in survival rate of HIV patients. But in case of the CD4 count, it's more than 50, there is no difference in survival rate when they use immediate antiretroviral, which is less than 2 weeks or within 2 weeks, compared with the duration from starting of antiretroviral after initiation of tuberculosis by 8 to 12 weeks. So if the CD4 count more than 50, we can defer the treatment of antiretroviral more than 2 weeks. Okay, tuberculosis meningitis. Why I mentioned tuberculosis meningitis? Because treatment with co-infection TB meningitis with HIV, it's shown high mortality plus high or severe side effect when they treat both infection. So that's why they prefer. We can see here when we use immediate antiretroviral treatment after initiation of tuberculosis, there is increased severities of side effect compared when we defer the treatment. So it's preferred to delay the treatment after 2 weeks of initiation of tuberculosis treatment. But if the patient with CD4 less than 50, it's better to start antiretroviral within 2 weeks, although the risk of IRIS is high. What about the pregnant and HIV pregnant and tuberculosis? If we have HIV pregnant with tuberculosis, we have to start the treatment of both infection. Of course, we have to start the anti-tuberculosis to avoid an IRIS, and we have to start the antiretroviral, the same thing within more than 2 weeks of the city for more than 50. As we know, we have to start antiretroviral to avoid the transmission from the mother to fetus. And for starting with anti-tuberculosis, it's better to start anti-tuberculosis because tuberculosis might increase the mortality for the fetus, and it's better to start it. But the problem is when the mother have multi-drug resistant tuberculosis, and actually most of the second line it's category C. So we have challenges with selected of anti-tuberculosis. So actually we have only bedaquiline and linezolid, which is safe for the ladies, pregnant ladies. Still, we have gaps regarding to the studies of use of anti-tuberculosis, which is the second line in MDR and XDR tuberculosis and the pregnant. For antiretroviral, it's a clear guidelines, and we have a lot of choices to be used antiretroviral and pregnant.
وجهي على فوق.
على فوق؟
وجهي كذا.
الوجه على وجه كذا؟ اوكي. طيب. اوكي. طيب. Moving to other challenges when we use antiretroviral with tuberculosis. As we know, rifamycin, it will cause a drug interaction with most of antiretroviral. So when we customize the treatment for HIV and TB patients, we have to look about the drug interaction between rifamycin group and antiretroviral, and to adjust the dose for even rifamycin group or antiretroviral. So this medication, which is NRTIs, ibalizumab and invetrafide, it's safe to be used with rifamycin group. No need to adjust it either rifamycin medication or dose medication. So we can use it together in HIV TB co-infected. Same thing with anti-tuberculosis. It's like pyrazinamide, ethambutol, and isoniazid. It's safe to be used with all antiretroviral. No need to check the drug interaction. So go specifically with rifampicin and rifabutine. Actually, there is a caution use of tenofovir alfenamide with rifamycin, and the packaging there, they didn't recommend to use this medication together, and they recommend to use tenofovir digoxin instead of tenofovir alfenamide, because they mentioned that it will decrease the concentration of TAF. Something rifamycin, it's contraindicated to be used with protease inhibitor, doravirine, ribavirin, and bictegravir, and bictegravir posted with cobicistat. But with other antiretroviral, it's safe to be used without any consideration. Rifabutine, the same thing when we use with protease inhibitor that posted with the cobicistat, and tenofovir alfenamide, it's contraindicated, so we have to switch with to other antiretroviral treatments. But when we use dolutegravir, raltegravir, efavirenz, and doravirine, it's safe to be used together with the rifabutine. But in case of using protease inhibitor with posted with ribavirin, so we have to decrease the dose of rifabutine to 150 instead of 300. With other antiretroviral, it's safe to be used these antiretroviral with rifabutine. Okay, rifamycin, when we when we start rifampicin with dolutegravir, raltegravir, and marvaric, we have to increase the dose of antiretroviral. For example, dolutegravir, we have to increase the dose from 50 milligram once daily to 50 milligram BID. While raltegravir, as I mentioned, we have to increase it to 800 Q12 hour instead of 400 Q12 hour. This is a pharmacokinetic study showed when they give TAF, tenofovir, alfenamide with rifampicin in healthy volunteer people, and they measure the concentration. They showed that TAF concentration showed it's about 4.2 fold higher than achieved in tenofovir digoxin. And they are working to check the concentration of TAF for HIV-infected patients with the TB receive both medication. So some expertise, they started to use tenofovir alfenamide together with the rifampicin according to the system. Okay. Actually, the iris reaction that's happened when we start antiretroviral treatment with TB patient, it causes high mortality for the most of AIDS patients. So when we start first when we start tuberculosis, anti-tuberculosis for TB-infected patients in HIV population, we consider to see iris within 3 months of starting of the treatment. Iris will cause mortality. Before we diagnose the patient with iris, we have to check about either treatment failure or what's the risk or what's the causes of deterioration of this case. Either the patient have HIV resistance or tuberculosis resistant. Patient, it might be not adhere to the medication, or there is an interaction that affects on the treatment. After we rule out these causes, so we have to diagnose patient or label patient with iris.
Dr. Rafa, 2 minutes.
Okay. So overall, it's about 18% of the patients have iris. Risk factors actually low CD4 count and high viral load when we start antiretroviral, and the shortest time between the TB initiation and antiretroviral. The mortality rate was high, especially in case of meningitis, TB meningitis. So the treatment is clear to use a steroid to treat iris reaction, and there is some studies to use prevention before the iris happen. So they start the patient on prednisolone to prevent the iris. TB drug resistance, it's increased the mortality of HIV due to the shared toxicity between the TB and antiretroviral. And we can see here the shared toxicity between antiretroviral and the TB, for example, renal toxicity with tenofovir, digoxin, and aminoglycoside, QT prolongation when you use evaporis with bedaquiline and quinolone. Sinus infection, the same thing with the use cycloserine and isoniazide with either evaporis, ribavirin, dolutegravir. This glycemia with the use lopinavir, ritonavir, zidovudine, and with the TB like isoniazid, paramine, salicylic acid. Medication that used for XDR, for example, bedaquiline, which is the safe, and this interaction with antiretroviral treatment, like bedaquiline, but the toxicity, the shared toxicity, which is QT prolongation, it might decrease the use of bedaquiline and XDR medication. With delamine, it is safe as drug-drug interaction, but it has QT prolongation and limited use in HIV due to its contraindicated to be used in hypoalbuminemia, which is common in HIV patients. Linezolid, same, there is no drug-drug interaction, but side effect like neuropathy, which is reversible in the patient. Finally, we have to talk about the prevention. Actually, TB prevention treatment coverage was just only about 49%, and it's decreased up to it's increased from 36 in 2017. Still, there is less data, or there is no reporting from most of the countries regarding the use of TB prevention. Actually, indication of the TB prevention, which is positive screening of latent TB or close contact with a person with TB, active TB, even the skin test was negative, we have to start the patient on isoniazid because there is no interaction with other antiretroviral. So, to conclude this lectures, actually tuberculosis, it is a serious infection, and it's the infection, especially if it's combined with HIV. The challenges of treatment of TB and retroviral or HIV, it comes from the development of iris when we start the treatment of both, and drug-drug interaction between antiretroviral and tuberculosis, and the shared toxicity between these two classes, and development of anti-drug resistance and extensive drug resistance. It will show the big challenge when we start the patient, HIV patient. Finally, WHO, they are working to decrease the TB prevention in HIV patients, and they try to offer the treatment of all HIV patients before develop with opportunistic infection. Thank you.
Thank you very much, Dr. Wafa, for this informative presentation. We will postpone the discussion until the end of the session. The next presentation will be presented by Dr. Aziza Ajlan. Dr. Aziza is a consultant transplant, clinical pharmacist in King Faisal Specialist Hospital in Riyadh. And she's going to speak to us about hepatitis C treatment and outcomes. So, follow Dr.
And thanks to the organizing committees on the patients. During this talk, we will talk about the ongoing gaps in viral hepatitis care. We will describe the factors on which therapy for hepatitis C infection depends on, recommend appropriate therapy for patients with hepatitis C infection using newly approved anti-HCV medications available in Saudi Arabia, recommend strategies to decrease the adverse events, and discuss potential barriers to achieving HIV 100% elimination of HIV treatment in Saudi Arabia. Now, this is just an overview. This is is just an overview of the WHO goals for viral hepatitis elimination. With the first thing to notice here that those guidelines or targets were first released on 2016, and they have tasked the entire globe with eliminating the viral hepatitis as a major health threat in by 2030. And those including 90% of infants have HPV vaccination at birth. 90% of injections should be administered with safety engineered devices in both in and out healthcare facilities, and for testing, 90% of the patients, 90% of the individuals who tested viral hepatitis positive should be led to care and treated. In line with the WHO goals, we should see a 30% reduction in new infections and 10% reduction of the health threat. There should be a 90% reduction in new infections and 65% reduction in deaths. Now, how do we achieve hepatitis C? How do we achieve the WHO elimination goals? Well, a lot of this focuses on prevention, which means safe blood and infection control, vaccination, harm reduction for individuals participating with high-risk behaviors, and preventing mother-to-child transmission. Most importantly, and at the right hand of this slide, we are also reminded to expand testing and initiation of therapy among those already infected. Diagnosis and treatment are really important when we are striving to eliminate the disease. Now let's focus on hepatitis C. As the case with hepatitis A and B, there's a red X here. This time for reducing the rate of reported hepatitis C virus infection. This was not much of an increase in the rate of infections between 2016 and 2017. But in the 2017 target was at a much lower rate, and we should be substantially impacting the transmission of hepatitis C. So there is a huge room for. This is the hepatitis C care cascade, identifying the most factors or the steps that the patient usually goes through when it comes to treating hepatitis C virus infection. However, unfortunately, and from the very publication of those factors, there has been gaps in the hepatitis C care cascade until the most recent one. There is apparently significant disparities have existed when comparing the number of individuals with chronic hepatitis C virus infection to those who are actually diagnosed and aware that they are carrier of the virus. So there's about 50% gap, or 50% of the patients with hepatitis C virus infection are diagnosed and aware that they have the disease. It's important to note that the guidelines all over the world are actually now changing to help us prioritize the screening. Initially, in 1998, the CDC guidelines has first recommended a risk-based screening for hepatitis C patients, which means that we have to identify people at risk by asking a bunch of questions. And by 2012, there was an emphasis to concentrate on the birth cohort, because people born between 1945 and 1965 had the highest concentration of infections. And then the demographic has really started to change with, so that in line with that, the American Association of the Study of Liver Disease started to recommend one-time screening for all individuals, for all adults from 18 years and older. And those recommendations were somewhat consistent between all international guidelines, the ASLD, the USPSTF, and the CDC. Now, there are some caveats here, that those guidelines actually recommend one-time outpatient screening for those individuals. Yet, this might not really be enough. You may screen a patient at a single clinic visit and they test negative, but they may still acquire the infection at a later stages. So we really should continue on our screening strategies if we are striving on, if we want to try to work on a micro-eliminating the disease. Why should we really focus on hepatitis C virus treatment? It has been consistently shown that in the literature that achieving SBR, which is the term for cure of hepatitis C virus infection, is associated with up to 80% reduction in all-cause mortality, 90% reduction in liver transplantation cases, and 60 to 70% reduction in the new onset hepatocellular carcinoma. And those findings were consistent across all patients populations, even when you look at the subpopulations, cirrhotic patients, transplant patients, or HIV co-infected patients. Now let's look at the pathways on treating hepatitis C virus infection. Well, as a matter of fact, the hepatitis C treatment cascade or the background of hepatitis C virus elimination has been really long and painful, with the path being ridden with slow-leading, low cure rate achieving, very interferon-based, long and painful therapy. One of the first medications that were introduced or tested to treat hepatitis C virus infection was actually cyclovir. Believe it or not, cyclovir was one of the medications that was investigated for treating hepatitis C virus infection, and it didn't demonstrate any benefit for the patient. Subsequently, or at around the same time, interferon was being investigated for the treatment of hepatitis B virus infection, and it did show some success. So people just thought maybe we can use it for the other hepatitis that was known at the time as a non-A, non-B viral hepatitis. So they started to use interferon for those patients. The National Institute of Health at the time, around 1986, was first to recommend the recombinant interferon used to treat patients with the non-A, non-B hepatitis before hepatitis C virus was identified as a cause of the disease. And encouraging results from this study prompted several mid-sized controlled clinical trials with interferon for the non-A, non-B hepatitis. And its partial effectiveness was confirmed. Interferon alone, dosed at 3 million units, 3 times per week, was used for 24 weeks and induced an end-of-treatment response of approximately 1/3 of the patients. However, most did not maintain the results or relapse. And this led to the sustained virological response, as is demonstrated here, as 6%. So several studies followed to investigate how can those results be improved. So people were started to work on extending those duration of therapies from 6 months to 12 months. And indeed, the results or the SBR rates did improve a little bit to 16%. Meanwhile, ribavirin was introduced to the market and it was reused alone. It managed to reduce ALT, alanine aminotransferase level, but it did not really cure the disease. However, when it was coupled with interferon for 6 months, it gave us SBR rates of 34%, and with the duration of therapy extended to 12 months, the corresponding SBR rates were 42%. And this has really been the situation, and all the focus was improving. All the focus of research was mainly on improving the half-life of interferon. So the pegylated interferon has come to place, and it was used following 2 approaches, with ribavirin and without ribavirin, and for 12 months or 24 months, and the SBR rates were pushed a little bit up to 55%. By 2010 or 2011, a new class of medication has started to occur or to come to the market, and we have started to see SBR rates of around 90% or above. So this graph represents the new era of or the evolution of hepatitis C virus treatment. Initially, the first hepatitis C direct-acting antivirals were used together with interferon, and it did manage to improve the SBR rates, which is the target that we are all striving to achieve. And after that, in 2013, the first approved interferon-free direct-acting antiviral sofosbuvir was introduced to the market. And this was followed afterwards with a tsunami of the new medications of direct-acting antivirals to control the hepatitis C, disease, and with excellent cure rate. The reason we are at such a wonderful position right now is because we have a wealth of oral therapies. And for those of you who are in HIV communities, the hepatitis C virus has followed the HIV paradigms. The key enzymes that allow the virus to replicate are shown here, and we now have a number of approved drugs that block each of these different enzymes. The two mainstays are combining protease inhibitor with an NS5A inhibitor, and then combining nucleoside NS5B polymerase inhibitor with an NS5A inhibitors. And now clinicians are choosing across wide range of classes of oral medication options. With the introduction of those medications, the HCV guidelines are moving towards improving access to treatment. Each one, whether from the ASLD, EASL, or WHO, recommends treatment for all patients with acute or chronic hepatitis C. And there are few caveats here, like for example, for the ASLD, they don't entirely recommend to treat patients if they have a limited life expectancy, but the general rule now remains that all patients should receive treatment regardless of their backgrounds or severity of their illness. Now let's look at the selection of the hepatitis C treatment option. I will only focus on the four main groups of hepatitis C medications, or the major first-line therapies of hepatitis C. What separates them, if any? Well, the first medication or combination of drugs, ibazivir regimen, is one pill once daily for 12 weeks for genotypes 1 and 4, making it a very attractive option. However, it's not a pan-genotypic option, and it has a very good results in genotype 1 and 4. Of importance, this medication does not require resistance testing if you are treating genotype 1A patient. It does include protease inhibitor, which you should not use in patients with decompensated cirrhosis, and it will come with a bunch of drug-drug interactions. The newest kid in the block would be licaprevir, which was approved in the end of 2017. It's a once-daily regimen, 3 pills given with food. And this may be an issue for patients who don't like to swallow pills. This regimen is a pan-genotypic. You can use it for genotypes 1 through 6, and thus it's a very appealing option. And for the patients who don't have cirrhosis or decompensated disease and has some significant drug-drug interactions, it can be used safely in renal patients or those on dialysis. Licaprevir can also be used in an 8-week regimen. So sofosbuvir is a single tablet daily. This is the most commonly medication that was prescribed, and there's an experience within the literature in terms of patients treated. It's a single pill once daily with an 8-week option based on low baseline viral load as well as some other disease-related factors. It does not contain a protease inhibitor, and that makes the drug-drug interaction intensity with it less compared to those containing protease inhibitor. So sofosbuvir with patisiran is another combination pan-genotypic regimen with activity against all genotypes. The drug-drug interaction profile is similar to those that we see with the patisiran, sofosbuvir. The problem with the last regimen is that you cannot use them with patients with renal impairment, creatinine clearance less than 30, or those on dialysis. Now, after we have reflected on how much progress we have made in the management of chronic hepatitis C infections over the past 30 years, starting from the interferon-based therapies and up to date, and we have advanced so much from that time to date. Now, we can focus on what can we do as a pharmacist for those patients. Now, we all believe that pharmacists have a key role in the treatment of hepatitis C as part of patient care team. And various providers have a role in optimizing the management of patients with hepatitis C virus infection. Prescribers, nurses, clinic staff, social workers, and pharmacists collaborate to identify patients in need of treatment and to obtain medication as these medications continue to be particularly costly. So, for example, if you want to treat a patient with suppository remdesivir in the kingdom, this will cost apparently up to $250 million per patient per treatment course. So one of the key components is that we have to apply medication therapy management, including identification of medication-related problems, significant potential drug-drug interactions that have an impact on the effectiveness of hepatitis C medication, and pharmacists can intervene on this front to prevent therapeutic failures. For drug-drug interaction, there are plenty of drug-drug interactions. We do normally recommend to visit a specialized website to address those drug-drug interactions, and we have touched base on key number of drug-drug interactions at the previous slides. Now, what are the information that you need to address prior to starting the patients on hepatitis C virus treatment? Well, number one thing is that we have to establish genotype testing because some of those medications are specific to certain genotypes. The fibrosis status, to what extent the liver has been damaged, and based on that we can decide on what treatment and what treatment duration you can proceed with. And if the patient is cirrhotic, then you need to calculate the Child-Pugh score to determine how the severity of the liver injury. Do they have chronic kidney disease? Are they on dialysis? What was their previous treatment history as patients with hepatitis C virus resistance? IV? What are their other concurrent medications? Because those are the key components when it comes to drug-drug interactions. When you counsel the patients about the hepatitis C treatment, they will be concerned about the pill burden. Some of the medications of the hepatitis C virus infection comes as a one tablet for all the patients. One of those like suppository remdesivir, so there won't be much of concern. There won't be much of concern when it comes to pill burden. However, other medications like lecaprevir, pibrentasvir, or even Vicirapac, that is composed of 4 tablets per day. And if you want to combine that with ribavirin, there's another 4 or 6 tablets added to the regimen. So a patient will end up with 10 more tablets per day just to treat hepatitis C, in addition to everything else they're already taking. 1 minute? 2 minutes maximum. 2 minutes? Right. The patient should be also counseled about the importance of adherence to medications. And this is one of the key factors of compliance, one of the 3 factors that leads to patients achieving their treatment outcomes. Now, I'll skip to the King Faisal experience because this is one of the key components of the presentations. Let's bring this now, all of what I've mentioned in the previous slides, closer to home. Kingdom of Saudi Arabia is one of the countries that has prevalence of hepatitis C, or that can reach up to 3%. There are different publications indicating what is the exact incidence or prevalence of hepatitis C virus in the kingdom, which range to 1 to 3%, which makes us one of the countries that are facing a real challenge when it comes to treating this disease. King Faisal Hospital is known as a tertiary care center and transplant center. And there's a rumor that says we have unlimited amount of resources, which is not really the case, especially for medications that can cause $250 million per patient per treatment
course. So we were faced with this challenge. We cannot just bring those medications, add them to the formulary, and let people prescribe them here and there, whether they are specialized or not. So what we did was we established a hepatitis C virus task force. The objectives of this task force is to evaluate the need, establish guidelines, carefully select the patients, carefully select the formulary items, controlling the cost, monitoring the utilization, and with that we have also established hepatitis C clinic, which is a multidisciplinary care clinic composed of physicians, nurses, and clinical pharmacists. The function of the task force was to recommend, it's a recommending body under the auspice of FTC, which is our PNT committee, to develop patient selection criteria, review safety and efficacy of available antivirals, recommendation to the FTC with regards to the most appropriate antivirals that should be available in patient formulary, and to develop medication guidelines for hepatitis C antiviral medication. Now, establishing the guidelines or putting criteria for patient selection was the most challenging part. However, our guidelines were in line with the international guidelines. When we initially started, we focused on the high-risk population, including those post-transplants or those who with decompensated cirrhosis. With time, our guidelines or some criteria have become more and more relaxed, and we started to include patients with co-infection or other comorbidities, until our current guidelines allows treatment for all patients with hepatitis B virus positive. Now, the second challenge was, how do we enforce those guidelines? Well, we have developed an indication form, which was a paper-based indication form, which composed of two parts. The first part has basic patient information or patient demographics that are essential in selecting, when it comes to selecting hepatitis C virus treatment and options and treatment durations, and the second part that clearly states the regimen. With time, we were able to automate this form and make it available for prescribing for physician electronically, before the need to go back and forth between the patient. This will also, the indication form also includes all the required therapeutic monitoring parameters at different time points of the care of the patient with hepatitis C. That leaves us with the biggest challenge, the cost. The first part shows how much did it cost really during the first year of the introduction of the hepatitis C virus infection. And as a clinical pharmacist, the director of pharmacy or the deputy of pharmacy administration calls me in a meeting every once in a while and to discuss those issues. So this doesn't really work for them. يعني director of pharmacy or pharmacy administration اللي أول حرفهم اسمهم دكتور الشناوي ودكتور الدبيع ويحسبون حساب الملكين. So this doesn't work for pharmacy administration ولا in hospital administration. So we have to really come up with a way of controlling the cost. Initially, we were starting to negotiate those prices with companies, and we managed to get a discount of 5 or 10%, but the volume of patients was really huge, and that did not really do the work. So we moved into a second approach, which is using generic substitution. Generic substitution was not an easy decision, with physicians really bringing up the concern, will this generic work? Will it work well? Will this work well for our patients? Why should we compromise the care of our patients by bringing generic hepatitis C virus medication to our formulary, especially that we are known to have the most difficult to treat population? What we focus on mainly is treatment outcomes. Now I would like to share with you a sample from the hepatitis C patients cohort that we treated in King Faisal Hospital. Those are the breakdown of the patient. I'll not go over it for the sake of the time. Our SVR rates remain above 10%, remains above 90% in all treatment subpopulation, including cirrhotic, transplant patients, and treatment experience. So this change in formulary, this formulary change did not only manage to control the cost, but also did maintain actually the efficacy of treatment in all patient population. This is the breakdown by genotypes. And With that, I conclude my presentation. However, yet we all have to be reminded that we are still far from the WHO targets, elimination target of viral hepatitis, especially of hepatitis C. We need to work together as a team across all institutions مع وزارة الصحة, of course, to achieve those targets, and we have to expand our care to include all the patients. Thank you.
طيب شكرا جزيلا دكتورة عزيزة. And again, we'll postpone the discussion till the end of the session. So the last presentation we have in this session is about the new trend, the hot topic, the novel coronavirus. So the topic of the title of the presentation is Another Decade, Another Coronavirus. Our speaker is going to be Dr. Abdel Abu Makarim, who is a professor of clinical pathology and a consultant clinical immunology from King Abdulaziz Specialist Hospital here in Taif.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم. At first, I would like to express my sincere thanks for the organizers to invite me to this valuable conference. And my talk today is the new virus, another decade, another coronavirus. 2019 nCoV, which causes COVID-19. Since December 8, 2019, several cases of pneumonia of unknown etiology have been reported in Wuhan, Hubei province, China. Most patients worked at or lived around the local Hunan seafood wholesale market, where live animals were also sold. In the early stages of this pneumonia, severe acute respiratory infection symptoms occur. Some patients rapidly develop acute respiratory distress syndrome, acute respiratory failure, and other serious complications, even death. On January 7, 2020, a novel coronavirus was identified by the Chinese CDC from the throat swab sample of a patient and was subsequently named 2019 nCoV by WHO. Laboratory confirmation of the virus was done in 4 different institutions: Chinese CDC, Chinese Academy of Medical Science, Academy of Military Medical Science, and Wuhan Institute of Virology. The throat swab specimens from the upper respiratory tract that were obtained from all patients at admission were maintained in viral transport medium. Sputum and or endotracheal spread were obtained at admission for identification of possible causative bacteria or fungi. Additionally, all patients were given chest X-ray or chest CT. The novel virus was confirmed by real-time RT-PCR using the same protocols described previously for other viruses. RT-PCR detection agents were provided by the 4 institutions. Other respiratory viruses, including influenza A virus, B virus, respiratory syncytial virus, parainfluenza, adenovirus, SARS, MERS, were also examined with this real-time RT-PCR. Much is unknown about how novel virus spreads. Current knowledge is largely based on what is known about similar coronaviruses. Coronaviruses are a large family of viruses that are common in many different species of animals, including camel, cattle, cats, and bats. Rarely, animal coronavirus can infect people and then spread between people, such as MERS or SARS, and now with the novel coronavirus. Coronaviruses cause illness ranging from common cold to more severe diseases, such as Middle East respiratory syndrome, Middle East respiratory syndrome in Saudi Arabia in 2012, and severe acute respiratory syndrome in China in 2002. Sorry for this. Novel coronavirus 19 nCoV is now a new strain that has not been previously identified in humans. Coronaviruses are zoonotic, meaning that they are transmitted between animals and people. Detailed investigations found that SARS coronavirus was transmitted by civet cats to humans. This civet cat is species of cats and found in Asia. MERS-CoV from camels and humans. Several known coronaviruses are circulating in animals that have not yet infected humans. As surveillance improves around the world, more coronaviruses are likely to be identified. Common signs of infection, including respiratory symptoms, fever, cough, shortness of breathing, and breathing difficulties. In more severe cases, infection can cause pneumonia, severe acute respiratory syndrome, kidney failure, and even death. On February 12, 2020, the disease caused by 2019 nCoV, which is called before SARS-CoV-2, is now officially called COVID-19 by WHO. Co, this corona, VI means virus, and D, disease. Certain recommendations to prevent infection spread include regular hand hygiene or washing, covering the mouth and nose when coughing and sneezing, thoroughly cooking meat and eggs, avoid close contact with anyone showing symptoms of respiratory illness such as coughing and sneezing. Can a human become infected with novel virus from animal source? The animal source of the novel virus has not yet been identified. This doesn't mean you can catch novel virus from any animal or from your pet. The cats not having this virus, or dogs or other pets. It's likely that an animal source from live animal market in China was responsible for some of the first reported human infections. To protect yourself when visiting live animal markets, avoid direct unprotected contact with live animals and surfaces in contact with animals. The consumption of raw or uncooked animal products should be avoided. Raw meat, milk, or animal organs should be handled with care to avoid cross-contamination with uncooked foods as per good food safety practices. The consumption of raw or uncooked animal products should be avoided. Raw meat, milk, most often spread from person to person happens among close contacts about 6 feet. Must be a person to be 6 feet from any persons having these symptoms or signs. Person-to-person spread is thought to occur mainly via respiratory droplets produced when an infected person cough or sneeze, similar to how influenza or other respiratory pathogens spread. These droplets can land on the mouth or nose of people who are nearly or possibly be inhaled into the lungs. It is currently unclear if a person can get novel coronavirus by touching a surface or object that has the virus on it and then touching their own mouth, nose, or possibly their eyes. Typically, with most typical viruses, people are thought to be most contagious when they are most symptomatic, the safest. With novel coronavirus, however, there have been reports of spread from an infected patient with no symptoms to a close contact. It is important to note that how easy a virus spread person to person can be. There are much more learn about transmissibility, severity, and other features associated with 2019 nCoV, and investigations are ongoing. This information will further inform the risk of assessment. There is currently no vaccine to prevent the novel coronavirus infection. The best way to prevent infection is to avoid being exposed to this virus. However, as a reminder, CDC always recommends everyday prevent actions to help prevent the spread of respiratory virus, including wash your hands often with soap and water for at least 20 seconds. Use an alcohol-based hand sterilizer that contains at least 60% alcohol if soap and water are not available. Avoid touching your eyes, nose, and mouth with unwashed hands, as these membranes are delicate. Avoid close contact with people who are sick. Stay home when you are sick to avoid transmit infection to others. Cover your cough or sneezing with tissue when through the tissue in the touch. Clean and disinfect frequently touching objects and surfaces. These are everyday habits that can help prevent the spread of several viruses. There is no specific antiviral treatment recommended for this novel corona infection. People infected with novel corona infection should receive supportive care to help relieve symptoms. For severe cases, treatment should include care to support vital organ functions. People who think they may have been exposed to novel coronavirus should contact your health care provider immediately. Treatment, there is no specific antiviral treatment. For severe, guidance for healthcare professionals. Limited information is available to characterize the spectrum of clinical illness associated with novel coronavirus. No vaccination or specific treatment for the virus is available, so care is supported. The CDC clinical criteria for novel COVID patients under investigation have been developed based on what is known about MERS or SARS-CoV and are subjected to changes as additional information become available. Healthcare providers should obtain detailed travel history for patients being evaluated with fever and acute respiratory illness. The CDC clinical criteria clinical features and epidemiological risk. Fever or signs, symptoms of lower respiratory illness, e.g. cough or symptoms of breath, and any person, including healthcare workers who has had close contact with a laboratory confirmed COVID patient within 14 days of symptoms on onset. Or fever and signs, symptoms of lower respiratory illness, coughing, shortness of breathing, and history of travel from Hubei province, China, within 14 days of symptom onset. Or fever and signs, symptoms of a lower respiratory illness requires hospitalization and history of travel from mainland China within 14 days of symptoms. The criteria are intended to serve as guidance for evaluation. Patients should be evaluated and discussed with public health department on a case-by-case basis of if their clinical presentation or exposure history is equivocal, uncertain travel or exposure. Recommendations for reporting, testing, and specimen collection. Health care providers should immediately notify both infection control personnel at their health care facility and their local health department in the event of a BUI, patient under investigation for novel coronavirus. In USA, state health departments that have identified a BUI should immediately contact CDC Emergency Operations Center and complete a novel coronavirus BUI case investigation from available. This virus, we don't know about it, clearly about it, but there is no treatment, no vaccines. So infection prevention and control is the important thing for this virus. As well as ensuring triage, applying standard precautions for all patients, implementing empiric additional precautions for droplet and contact, and whenever applicable, airborne precautions. implementing administrative controls using environmental and engineering controls. The first one, ensuring triage, early recognition, and source control, isolating patients with suspected novel coronavirus infection to facilitate the early identification of cases of suspected novel corona infection. Healthcare facilities should ensuring encouraging healthcare workers to have a high level of clinical suspicion, especially if coming from China. Establish a well-equipped triage station as the entrance of the healthcare facility, supported by trained staff. The use of screening questionnaire according to the updated case definition, both science and public areas. The promotion of hand hygiene and respiratory hygiene are essential preventive measures, reminding symptomatic patients to alert healthcare workers. Second item, applying standard precautions for all patients. Standard precautions include hand and respiratory hygiene, the use of appropriate personal protective equipment, PPE, according to the risk assessment, safe waste management, proper linens, environmental cleaning, and sterilization of patient care equipment. Third item, implementing empiric additional precautions, contact and droplet precautions. In addition to using standard precautions, all individuals, including family members, visitors, and healthcare workers, should use contact and droplet precautions. Patients should be placed inadequately ventilated single rooms. When single rooms are not available, patients suspected of being infected with novel coronavirus are brought together. All patients' beds should be placed at least 1 meter apart. Contact and droplet precautions. Healthcare workers should use medical masks, wear eye protection goggles, facial protection, face wear clean, non-sterile, long-sleeve gown and gloves. After patient care, appropriate disposal of all
الفيديوهات اللي ارسلت عليك ارجع ارسل علي.
Equipment should be either single-use or disposable or dedicated to the patient. Two slides. Airborne precautions for aerosol procedures. Fourth item, implementing administrative controls, provision of adequate training of healthcare workers, ensuring an adequate patient-to-staff ratio, establishing surveillance process for acute respiratory infection, ensuring that healthcare workers and public understand the importance of promptly seeking medical care, monitoring healthcare workers' compliance with standards. The first item and the last item, using the environmental and engineering controls. These controls address basic and infrastructure of the healthcare facility, aim to ensure there is adequate ventilation in all areas of the healthcare facility, as well as adequate environmental cleaning. Additionally, spatial separation of at least 1 meter should be maintained between all patients, ensuring that cleaning and disinfection procedures are followed consistently and correctly. And thank you. This presentation and the other brochures from MOH and from CDC and WHO are here with the organizers, and if anyone wants to contact me, it is easy to contact me in King Abdulaziz Specialist Hospital, Immunology Department, and Science.
Thank you very much. Thank you very much, Dr. Abed, for this informative presentation about the novel coronavirus. طيب الآن حنفتح بس الباب للأسئلة والنقاش. إذا أحد عنده أي سؤال للدكتورة وفاء بخصوص التي بي and HIV، أو دكتورة عزيزة hepatitis C، أو دكتور عابد coronavirus. Any questions؟ عشان لو ما في أي سؤال تفضل. في سؤال منه. طيب ممكن الدكاترة إذا ممكن تتفضلوا.
السلام عليكم. So, Ahmed Rateri, clinical pharmacist. My first question, if you don't mind, I have 3 questions, if you don't mind. My first one is to Dr. Wafa regarding the newly admitted patients or admitted patients with extrapulmonary TB after successfully completed pulmonary TB treatment. So, if she can recommend us about the approach for this patient.
Okay, your question, if the patient have a previous infected with pulmonary TB, then readmitted with extrapulmonary TB.
Yes, this is the question.
Okay. When we manage this case, we manage as extrapulmonary tuberculosis, but we might reconsider question about reinfected. We will not consider as relapse because the site of infection is different. Okay, so we will start according to the previous sensitivity test of antimicrobial. If there is multi-drug resistance or extensive drug resistance, if it's susceptible, so we consider the treatment as extrapulmonary TB, start with initial phase, then continuation phase. And according to the site of infection, we consider the duration. A minimum 6 months up to 12 months if it's meningitis.
Okay, my second other 2 questions is for Dr. Aziza. First, regarding whether there is documented or in the incidence of HCC post or compared to SB12 compared to SB24, SBR12 compared to SBR24, and the prevalence of HCC later on. Does it matter whether the patient achieved the SBR within 12 weeks post-completion therapy compared to 24?
Shukran, Ahmed. Thank you for the question. Now, there is no reported difference between SBR12 and SBR24. If you remember, at the interferon era, SBR used to mean sustained virologic response 24 weeks after completion of treatment. And with the introduction of direct-acting antiviral, there's a new definition that has been introduced, which is SBR12, which is 12 weeks sustained virologic response, 12 weeks after completion of therapy. What we found from clinical trials is that SBR12 represents 99% of patients, 99.2 or 0.3 actually, percent of the patients who achieve SBR12 will also achieve SBR24. There are no known reports that look specifically into the breakdown, whether those patients have different incidents of emergence of HCC. But also, we don't have a reason to think that the dose will be different because what we're looking at is cure. And once the patient achieves cure, then the risk is gone, or the risk is eliminated. So we don't have any reason to think that those incidents of HCC will differ between SBR12 and SBR12.
Okay, it means no relation to the earlier response to therapy. Okay, my last question is regarding DNR patients and DAAs. And the same thing for other also ordinary patients with receiving broad spectrum antibiotics. We are suffering actual problems with DNR patients. We have to continue treating them with either highly expensive like DAAs or broad spectrum ones in case of they are already DAAs are admitted. For some patients, I have noticed some as OPD and labeled as DNR, as you know, terminal cancers. So are we still giving it?
I think DAAs are slightly or quite different لما نتكلم عن antibiotics. So antibiotics, you are treating septic shock or something that the patient can die in an hour or two. But when you treat patients for hepatitis C virus infection, you mainly are preventing long-term outcomes, mainly developing of cirrhosis or decompensated cirrhosis requiring transplantation, or preventing HCC and mortality that comes from those two disease states. So if you want to invest in treating patients to prevent death that will not occur in بعد 10 سنين أو بعد 15 سنة, different than preventing a disease or death that will occur in few hours. So for patients with who are DNR, for a patient with pre-existing cancer, disseminated, unresectable cancer, who have a limited life expectancy of 6 months, treating their hepatitis C will really not add much to their prognosis. And that's really different from treating a patient with septic shock or any other infection. So what is the long-term outcomes that you are looking for? And from that, you can decide to treat your patient or not to treat your patient with direct-acting antiviral. Now, that does not apply on patients with decompensated cirrhosis. The one exception of this rule is decompensated cirrhosis, because actually clinical trials have shown that treating decompensated cirrhosis actually helps stabilizing their cases, lower their MIT scores, and give them longer time on waiting lists to transplantation, awaiting for more suitable cadaveric donors. So generally speaking, to make long story short, if the patient is a DNR or has life expectancy of, generally speaking, less than 6 months, we don't recommend treating them. But all other patient population, you may invest actually in giving them those medications.
Thank you so much.
Thank you very much for our speakers.
يعطيكم العافية. ننتظر الدكاترة شوي بس. دكتور انتظر شوي. نرحب بالدكتور بدر الحارثي لتكريم المتحدثين. دكتور أبرار ثابت. دكتورة وفاء الفهد. دكتورة عزيزة عجلان. دكتور عابد أبو المكارم. يعطيكم العافية. نكمل بقية الجلسات مع دكتور عبد الله. أهلا وسهلا.
السلام عليكم ورحمة الله وبركاته. أخوكم عبد الله هيفاني، وكيل كلية الصيدلة بجامعة ابن القرى، ومستشار المتفرغ مع الزملاء في مجمع الملك فيصل. السيشن الآن التالية راح تكون عن الأبديتس in pharmacotherapy of type 2 diabetes mellitus. عندنا 2 pioneers صراحة في المجال، 2 يعني distinction speakers. الدكتورة بشاير الصوينة حاصلة على شهادة البكالوريوس في الصيدلة الكلينيكية من جامعة الملك سعود. أكملت تدريب البي جي واي 1 والبي جي واي 2 في تخصص الرعاية الأولية بالمدينة الطبية بجامعة الملك سعود بالرياض. حاصل على البورد الامريكي في العلاج الدوائي وشهاده مثقف صحي لمرضى السكر، مهتمه بالامراض المزمنه والطب الوقائي وابحاثه، محبه للعمل التطوعي، وشاركت مؤخرا في 2019 مع فريق هيئه الولايات الاسلاميه للرعايه الصحيه في دوله موريتانيا بافريقيا. حاليا تشغل الدكتوره منصب صيدلي كلينيكي في تخصص الرعايه الاوليه في مستشفى الملك خالد الجامعه بالرياض، عنوانها Anti Diabetic Agents and the US FDA Warnings. تفضل دكتور بشاير.
Thank you, Dr. Abdullah, for your introduction, and a special thanks for the organization committee for their invitation. So, in order to start my talk about the US FDA warnings or black box warning against anti-diabetic medication, let's Okay, so let's start reviewing the evolution of anti-diabetic medications. So this is a timeline for the discovery or the development of different anti-diabetic medications. And you can see that since the 1920s till the 1950s, the only medications were used as different types of insulins, which is the injectable dosage form of medications. Then by the 1950s, the start was with sulfonylureas, the very first oral dosage form of antidiabetics, and which makes it a special era is that multiple or many patients would have a semi-resistance against the use of injectable dosage forms in treating their conditions. So we were very glad and happy with the introduction of the oral dosage form in managing of diabetes condition. However, with these many medications, we were especially cautious to make sure that these medications are safe. And in order to make sure that these medications are safe, and we always remember that most of us, if not all, make this promise to make sure that whatever intervention we're providing to our patients is made for their safety, not to harm them. So for the same reason, the FDA have many phases in order to approve whatever medication coming to the market. And additionally, the last phase would be what's called the post-marketing surveillance studies, which is the evaluation of medication after being marketed and initially approved to be used for patients. Why do we need such studies? It's because we're using these medications on real-life patients. We know that studies, they're using a controlled environment where the patients are idle with normal functions, ages with a certain group. So extreme ages is usually excluded. Patients with impairments are excluded. So this is why it's important to make sure that even after the approval of medication, the medication is still safe and giving the promising effective effect. So this is the most famous communication for safety regarding one of the medication that was earlier produced by one of the companies, which is the Avandia, or as generic name is the rosuloxazone. The medication for diabetes management is effective. It's one of the good medications to treat diabetes. However, the issue was just soon after the approval and the use of the medication, multiple patients had cardiovascular events, especially those with history of
heart failure or similar conditions, and this led to what we call the black box warning for such medication. So the black box warning was for additional labeling information for those patients, that we should make sure that those patients are not with history of cardiovascular disease. Also, for those patients who already used the medication, we should make sure that they are having this as an option after a trial of very different medications to manage their condition, and this is the best option for them recently. With the same group, we have, from the same class, we have different medication that has also the same or similar black box warning as the rosiglitazone. So patients with a history of congestive heart failure should be cautious after the start of this medication. We should make sure that we're selecting this medication because it's the best available for this patient. We've tried a lot of different medication, and also after initiating, we should make sure to explain whatever signs of symptoms related to the black box warning if the patient develops any. The other medication is the commonly used as a first-line medication. It's the metformin. The black box warning for this medication is the lactic acidosis. We know that this condition is considered to be rare, and actually it's very rare condition. However, if it's happened, it's life-threatening and patient might die. So proper counseling for this patient to make sure that the patient know that this condition is rare. However, if they have unexplained symptoms or whatever abnormalities, how to deal with it, they should immediately seek for help. The third medication is the semaglutide, which is one of the GLP group. Those medications are used as an injectable form. However, they are proven to be very effective in managing diabetes condition. So with these medications, after the approval of those medications, there were a black box warning regarding that during the animal studies, they had an increased rate of thyroid cancer, especially the C-cell tumors, with the use of this medication. Although this happened only with very high doses, which is normally not used by humans, also during the prolonged period. However, because this happened, even if it's an animal, we should be cautious with patients. So lastly is the SGLT2 group, specifically with the canagliflozin, which is also effective medication. However, increased limb amputation with this medication, and we know that the diabetic patients would always fear of having gangrenes and end up having amputations. So giving medication to treat their diabetes, but having the same conclusion would not be very satisfying for the patient. So we should always make sure that the patient are being used the most effective dose for them. And we have recently, most of us heard of the contamination or having traces of NDMA and metformin product. However, the FDA says that it's very minimal amounts and is not considered for recall. So for all patients using any medication with black box warning, whether it's anti-diabetic or a different medication, we should always make sure that those patients knows that this medication is being selected to help them. We should make sure that those patients knows exactly whenever they had unexplained symptoms or symptoms related to the black box warning, they should seek for help and ask their primary care providers. We should always encourage the patients and healthcare providers to report any abnormalities or side effects, whether it's registered to the previously in the FDA or it's not. And we have also the what's called the MedWatch for reporting the adverse events. And whenever we choose a medication with a black box warning for a patient, we should explain to the patient that we're choosing the most safe and effective medication. We know that it carries a black box warning. However, since it's best for this patient, and we should always tailor our medication therapy to fit for a patient specifically. So I would end up by this saying, which is repair and prevent. Prepare and prevent, do not repair and prevent. Thank you.
Thank you so much, Dr. Shahir. It's really informative presentation, and really this brings us back to the debate. Some fellow physicians, they are always like hesitant to experience new medications. But I have too many questions. Maybe Dr. Shahir, inshallah, will postpone it till the end. Our next distinctive speaker, دكتورة عائشة بدر، حصلت على شهادة البكالوريوس في الصيدلة الكلينيكية من جامعة الملك عبد العزيز. أكملت تدريب البي جي واي 1 في سانت إليزابيث في بوسطن ماساتشوستس. أكملت البي جي واي 2 في الرعاية الأولية بجامعة أريزونا بالولايات المتحدة الأمريكية، وكتخصص دقيق في مرض السكري، أمراض كبار السن، وإدارة العلاج الدوائي. حاليا تشغل الدكتورة منصب أستاذ مساعد بقسم الصيدلة السريرية في كلية الصيدلة بجامعة الملك عبد العزيز، وأيضا تدير دكتورة عيادة الأمراض المزمنة بمستشفى الملك عبد العزيز الجامعي. فلتتفضل دكتورة عائشة مشكورة.
السلام عليكم ورحمة الله وبركاته. بصراحة حابة أشكر دكتورة بشاير على her informative presentation as well مع black box warning حق medications حقت diabetes. Today I'm going to talk about the new oral antidiabetic agents اللي they worked on بعد اللي هو FDA when they made the issuance of their warning, and they mandated all clinical trials to have cardiovascular outcome trials to prevent and with cardiovascular problems. So today I'm going to talk about the role of novel anti-diabetic agents in patients with cardiovascular diseases. So the major objective of this presentation is to first of all understand the main objective of these cardiovascular outcome trials that I'm going to refer to as CVOTs throughout the presentation. For type 2 diabetes mellitus, we're going to list major CVOTs for type 2 diabetes mellitus for the past 7 years for novel anti-diabetic agents. I'm going to focus mainly on those who had superiority in comparison to placebo, so majorly the SGLT2 inhibitors and GLP-1 receptor agonists. We're going to identify drug classes that have demonstrated the greatest cardiovascular benefits. And finally, we're going to align these CVOTs trials and their findings with the most relevant guideline recommendations. So as Dr. Bashir has mentioned, rosiglitazone with the cardiovascular problem that they caused, which is mainly heart failure, the FDA has mandated all cardiovascular outcome trials to do these trials and report the safety of their medications and drug classes. The cardiovascular outcome trials are characterized by 3 things. So first of all, they included high-risk patients, so they no longer include the healthy patients in the trials, but they majorly focus the high-risk patients, including the elderly population. They also wanted to show either non-inferiority when comparing to placebo, and if that was shown, they also extended it to show superiority in comparison to placebo. Sorry. So all throughout the presentation, we're going to present the trials, the major trials. We're going to say what the medication was in comparison to placebo, what doses were used, and so on. They're going to be presented by a hazard ratio. So anything below number 1 would show superiority in comparison to placebo. These agents actually were canagliflozin, empagliflozin, liraglutide, semaglutide and recently dulaglutide was actually added to the list. And I'm going to discuss with you all these trials. And if they were, the hazard ratio, if it was between 1 to 1.3, sometimes it's relatively more than 1.3 in certain trials, they would be deemed non-inferior. Up till now, no medications or no trials has shown any cardiovascular problems after the 2008 FDA CBUT recommendation. The evaluation of all these cardiovascular outcome trials focused on something called MACE, and this is for major adverse cardiovascular events, and they include, first of all, cardiovascular death, followed by non-fatal MI or myocardial infarction, and non-fatal strokes. Also, I'll refer to them as MACE throughout the presentation. So as you can see, this traffic of clinical trials have happened after the 2008 FDA mandation. So from 2013 to 2020 are the major trials, which is in the past 7 years. The main traffic has happened between the SGLT2 and GLP-1 receptor agonists, which are highlighted in red and orange. Also, the TDP4 inhibitors were also having some trials going on. But probably after the sabertene, which had the saxagliptin, there was more hospitalization for heart failure patients. The DPP4 were kind of backing off with their trials. But because of the LEADER and EMPEROR trials that showed a lot of cardiovascular benefit, a lot of other trials have, a lot of companies, pharmaceutical companies, have wanted to show the same thing with their medications. So as you can see, so many trials of the GLP-1 and SGLT2. Today, I'm going to focus on the ones that showed superiority, and these are highlighted in red and orange for both the SGLT2 groups and GLP-1 receptor agonists. First of all, I'm going to start with the GLP-1 receptor agonists, which are the subcutaneous injectables. And probably the most known one here in Saudi Arabia is Victoza, and known as liraglutide for generic. The benefit of this group is, first of all, they improve satiety, which makes patients more, we'll talk about that later, but anyway. They promote weight loss, they improve cardiovascular outcomes. I'll talk about the medications and the trials after a while. The common side effects for this group is nausea, vomiting, and diarrhea, and some would say that this is the reason why a lot of patients lose weight in the beginning of the medication treatment. It does have some hypoglycemia that is seen when added with sulfonylurea and insulin. It does have an increased risk of gallbladder events, and only with semaglutide have we seen an increase in retinopathy complications. The FDA-approved agents are as shown to you in the slide. I'll start with the major trial, which is the LEADER trial that changed a lot of things in diabetes and all throughout the guidelines that came out of after this trial. So the LEADER trial was studying the liraglutide in comparison to placebo. And as we mentioned, in these trials, we always focus on high-risk population. So as you can see in the eligibility criteria, it was either patients over the age of 50 years old or over the age of 60 years old. For those over 50 with more than one coexisting cardiovascular condition, and for those over 60, at least they would have over one cardiovascular risk factor. The comparison of both the liraglutide and placebo arm, they had liraglutide in the recommended dosage, and for the primary outcome, it was all MACE, and for the secondary outcome, they added revascularization, hospitalization for unstable angina, or heart failure. As you can see here, for the hazard ratio, it showed superiority in everything related to MACE, so everything under 1 was favoring liraglutide. And so after that, the FDA has issued that liraglutide at the doses from 1.2 or 1.8 milligram to reduce the risk of major adverse cardiovascular events. It was approved without benefit. After that came the SUSTAIN-6 trial, and it studied semaglutide. Semaglutide was more favorable than liraglutide in the way they would inject it. So this is a once-weekly injection. And they wanted to see if it had the same outcome as the liraglutide medication. As you can see also, same thing, high-risk population. Primary outcome for all trials was MACE, and in addition to, in this trial, they wanted to look at microvascular outcomes. So they did include patients, they did want to see retinopathy complications, newer worsening nephropathy, and also some any hospitalization for heart failure patients. Unfortunately for this trial, the primary hypothesis confirmed that semaglutide would not be inferior to placebo, which is okay. However, for the retinopathy that they wanted to look at and to see if it had any better outcome, it was actually favoring placebo. And for that, there was actually see if it had any better outcome. It was actually favoring placebo. And for that, there was actually a black box warning regarding this. After that, there was the Excel trial that looked at exenatide. And I'm not going to bore you with the details, but it's basically the same thing, the high-risk population, and they wanted to look at MACE, and also it did not show, it wasn't, the events did not differ significantly between patients with placebo and this medication, for exenatide. And finally, probably the last of this medication group was the REWIND trial that was published, the results were published in September last year. And it was superior, and the major thing of this trial, they included patients with or without major cardiovascular problems, so they did include not only high-risk patients, but normal patients as well. So as you can see, the conclusion was they did show significant reduction in cardiovascular adverse events with dulaglutide compared to placebo, and the benefit was shown in patients both with or without cardiovascular risk factor, but no underlying diseases. Okay, so now moving forward with the SGLT2 inhibitors. The benefit of this medication class is, first of all, low hypoglycemia rates, even when we compare it to GLP-1 receptor agonist. It did have small triglyceride reduction rate. It did decrease uric acid level, and some may say it's because of the mechanism of action of the medication itself. It did have blood pressure reduction and weight loss, and this is probably secondary outcomes that the medication is still looking into. Cardiac and renal benefits in patients with established or high-risk ASCVD, atherosclerotic cardiovascular disease, and this was particularly with empagliflozin and canagliflozin. Now, major risk or side effects for this medication group is the UTIs, or urinary tract infection, in addition to genital mycotic infection. Polyuria and dehydration, also based on the mechanism of action, some sort of diuresis is happening with this medication. Small increase in LDL level, diabetic ketoacidosis, and acute kidney injury. With canagliflozin, there were two side effects that were specific to the canagliflozin, and maybe you've seen with the trial of the canagliflozin, which was actually lower limb amputation, as Dr. Bashir has mentioned, and fractures as well. Okay, so for the major trial for this SGLT2 group was the EMPEREC trial, and also they compared the medication with placebo in two different doses, 10 milligram and 25 milligrams. This medication, empagliflozin, has showed superiority over placebo for the MACE that we mentioned before. And relative risk reduction was actually very big with this medication, with 14% for primary outcome, and 32% for all-cause mortality, and 38% for cardiovascular death. So this makes this medication very favorable in atherosclerotic cardiovascular disease patients. They also wanted to look at renal outcomes over 3.2 years of follow-up, and they found that for the incidence of worsening nephropathy, the relative risk reduction was reduced by 39%, and for macroalbuminuria, it was reduced by 38%. Again, this is a really big percentage, especially looking at microvascular complications, in addition to the macrovascular complications that were mandated by that day. Okay. After that, the AFDA also approved empagliflozin to reduce cardiovascular death in adults with type 2 diabetes, and this was in 2016. All right, so after this major trial came another trial, and it happened in 2 phases, the Canvas and Canvas R. The Canvas R from the letter R is for renal, so they also wanted to see the renal outcome after the results that came of the empagliflozin. This medication focused on canagliflozin, and it was actually approved before the empagliflozin, but the results came out in 2013. And after that, they did the renal study in 2014. So for canagliflozin, it was compared in doses of 100 milligram and 300 milligrams. Okay. And for the results with statistical significance, it was also the MACE, so the death from cardiovascular causes, non-fatal myocardial infarction or non-fatal strokes. And also, they showed significance in hospitalization for heart failure, in addition to progression of albuminuria and estimated GFR reduction of 40%. So again, a big percentage compared to other medications and other within this class. So again, same thing happened with this medication that mentioned Dr. Bashir, the black box warning for amputation, and in addition to the cardiovascular benefit of this medication. And also for all SGLT2s, they saw in all trials the risk of urinary tract infection and the serious infection of the genitals in the area around the genitalia. So with these, as mentioned with Dr. Bashir, proper education, patient education is all what we need. So proper hygiene of the area will probably do what's necessary for these patients. Finally, the summary of these trials in type 2 diabetes and their impact on the guidelines. First of all, the ones that showed benefit with the MACE and cardiovascular outcome trials, 2 from the SGLT2 inhibitor groups, which is empagliflozin and canagliflozin, and 3 from the GLP-1 receptor agonist, which are semaglutide, liraglutide, and dulaglutide, and this was the newest dulaglutide. Secondary endpoint of decreased all-cause death was significantly reduced with empagliflozin, zenitide, and liraglutide. And hospitalization for heart failure was only reduced in the EMPERACT. However, with the renal outcome, it was also seen with other medications within this class. So what happened to the guidelines? Since majority of us use the ADA 2020 guidelines, I wanted to highlight that in the guidelines. So first of all, for the ASKD predominance, the preferred agent after, of course, metformin, which is the drug of choice, the recommendation is to add a GLP-1 receptor agonist. And if it wasn't favorable by the patient, let's say for it being subcutaneous or something like that, we can use the SGLT2 as a second line. For heart failure or chronic kidney disease, the favorable agent is SGLT2, followed by GLP-1. Now, the reason for this could be the mechanism of action. As we mentioned before, probably with the diuresis in heart failure and chronic kidney disease, it might add the benefit and the risk reduction as well. Finally, I hope I didn't bore you with a lot of trials. I tried to summarize as much as I can. The trials were actually summarized by the American Association of Endocrinologists, so that aided me a lot in doing this presentation. I'll take any questions. Thank you.
Thank you so much, Dr. Aisha. So now for a question, if Dr. Aisha and Dr. Shahid, please. Isra.
السلام عليكم. أسامة الفايز من كلية الصيدلة بجامعة القصيم. طبعا I don't like to ask questions, but I will, if you don't mind, I have a comment, just a couple of comments. I mean, we don't like to see black box warnings, of course, for any medication, but it's always important to look into why or what can partly at least explain that problem. So with the semaglutide once weekly, they wanted to see microvascular complication, and they end up having a problem with worsening of retinopathy. And that can partly be explained by, we already know that when you improve glycemia very quickly for those with already with retinopathy, that actually can worsen retinopathy. And semaglutide is one of the potent GLP-1 receptor agonists. So that was, I would say, partly explaining why we saw that worsening of retinopathy. So it's always, we need always to be careful how to look at those box warnings, or black box warnings. Now, for years we were having problems on what would be the second medication to start after metformin. And I think we have now some evidence that probably in the next 2 years, even starting with one medication will not be enough. And we have some data to support dual therapy from the beginning. But for cardiovascular outcome trials, since this is the area that I love the most about diabetes, actually the guidelines didn't help us in terms of which one to pick. So they only looked at MACE, and they say, well, if it decreases MACE or decreases cardiovascular outcome, major adverse cardiovascular events, then that should be used, or that should be preferred. But we're still having problems because we saw a class effect with SGLT2 inhibitors, especially when it comes to progression of kidney disease and heart failure hospitalization. But when we look at the other outcomes, it's inconsistent. Same thing with GLP-1 receptor agonists. One time, with one medication, MACE was driven mostly by decreasing unpaid stroke. In another trials, mostly driven by death. So we still don't have consistent accuracy results when it comes to that. So it's still, we have, the way we look at diabetes now has changed, the way we treat has changed, and now we are more friends with cardiologists than we will ever be before. But we still have a problem which one to pick for those who have shown efficacy.
I totally agree with everything you said, Judge Osama. Thank you for your comments, definitely. I think because there are new medications, there's only going to be some time, and maybe head-to-head trials that can show the main favorable agent out of the entire class, or maybe compare head-to-head this class, the SGLT2 with the GLP-1. Again, they're new medications, relatively new medications. They haven't been in the market out for so long. So only post-marketing studies and head-to-head trials will show that, but I totally agree with that.
One more addition to Dr. Aisha, I totally agree with both of you, and we should always tailor our therapy to the patient specifically. So if the patient will be providing medication, if the cost issue, this is going to be considered. If the patient have another comorbidities, for example, obesity or something else, this is also should be considered, and so on.
I have one comment, Dr. Shina, if you don't mind. Regarding starting with more than one agent at the beginning, to be honest, I see in my scope of practice, where I practice, that many physicians, they start with newly diagnosed patients right away with 2 or 3 agents, without really emphasizing diet, regimen, lifestyle modifications. Really, my personal experience, I had a patient who came into my clinic 3 months before he showed up for his new aim. So the A1C, he came in with A1C 5.2, and his previous A1C was 9 something. That was like abrupt decrease. And he actually came in because he was complaining with palpitation in his heart. So, Dr. Bashar, I totally agree with you. We need to really tailor the management. Yes, there is no there's no honestly a way we can treat all the patients with the same method. And this is this is where, mashallah, I've noticed, I've seen your meta-analyses, and this is where it comes like these evidence, we built all these evidence to give the information, the needed information for the provider, for the physician, for the treating physician, to make a good decision. But honestly, I really emphasize tailoring and looking an all perspective cost. Is the drug will be stopped after 6 months? This is one of the issues that I encounter. I will start the patient like baclofen, and after 6 months, the drug is out of stock, and the patient can't really buy it from outside. This is a big issue. I think we really need to look at there's too many factors to make a decision, and this where research and it's commonplace. There's a question here with Dr. Demirtaş.
Thank you. Actually, it's not a question, it's like a follow-up. Just want to welcome all the endocrinologists to the cardiology world, so welcome. I think the comment that Dr. Sam mentioned is really valid, but we have been seeing this with hypertension for years. So if I ask you what is the first line therapy in hypertension, there's no such thing. As long as you look at the comorbidities, what the patient has, and this is how we treat our patients. Same thing when it comes to these agents. When you look at chronic diseases, diabetes, hypertension, they never stand alone by themselves, dyslipidemia. Most likely every patient would have 2 or 3 comorbidities at the same time that can target your therapy, either by high risk, by lower risk of this or that, and that's how you can manage. For example, if I have a heart failure patient, I'm going to start this patient on dextrose. It's not a question. I have evidence, I have how it works. I'm not going to question too much stuff. Although there is no in the guidelines, they do not tell you to do this. So my other question to you guys is just for everyone, it's not from one specific. Now having all these medications, the endocrinologists and the cardiologists, if you look at the P&T committees, they are fighting on which medication they should add to the formulary of the hospital. So, at this point you have to pick something that hits multiple goals for you. Something that can help you in cardiology, something that's going to help you at the same time in managing your diabetic patients. Again, there's no right answer for this, but from anyone's from the audience and the speakers, would have a comment on which medication we think you maybe favor that can cover a broader spectrum of patients.
Okay, thank you for the question. It's a very actually tough question. We actually just discussed this as we were having breakfast this morning. It's very different from one hospital to another, and again, with these agents, they're not available as generic. They're still as brand names. They're very expensive. We're talking about in like 1 month therapy, it would go up to 2,000 riyals in certain medication of this group. So they're very, very expensive. So when it comes to formulary and giving patients, or like what would happen in the hospital, especially it's a government hospital, the Saudi FDA have a list of necessary medications, and actually for endocrinology or diabetes, they have sulfonylurea and insulin. That's it. So these 2 are the necessary medications deemed by the Saudi FDA. When it comes to patients, it depends, do they have any way of paying for the medication, any insurance companies paying or so. If that's the case, a very detailed maybe decision made by the doctor themselves and the patient in discussion. They discuss all the benefits and risks, and then they come up with a choice. But that's a very good question.
I think really from a clinical perspective, honestly, I would love to have all of them. Honestly, I would like to have all the options when I give recommendation or I give. But really, from I recently joined administrative as an RPD, and I've noticed that it's really difficult to have them all. I would say sustainability, having a drug that I can rely on, that it will be available for a long time period. One of the issues that honestly I'm pleased is like you could face it when you practice is we start a patient on a medication and suddenly the drug is out of stock, and this is a big issue. I mean, with diabetes, but when it comes to anticoagulants, oh my goodness, it's really scary. So, if I'm in a PT committee, I would make sure sustainability is one of the factors to consider.
Yeah, I mean, I look at it from an ideal world perspective. So let's assume cost is not an issue and everything is not, I mean, we don't have many issues. In that case, we need at least one from each class, the new medications. For the GLP-1 receptor agonist, we actually looked at all those trials in addition to Pioneer 6, which is the first oral semaglutide, and albiglutide, which is not in the market no more. And we did a network meta-analysis, and we found that when you look at cardiovascular outcomes data, specifically cardiovascular outcomes, it seems like semaglutide is preferred. Semaglutide injection once weekly is preferred compared to the rest.
Is that meta-analysis?
Yeah, but still, I mean, it's still, that's based on some data at least. It's better than just picking whatever you like. So if I would pick one of the GLP-1, I would pick semaglutide injection and semaglutide oral as an alternative. But again, this is not an ideal world.
I like from yesterday's sessions, our colleagues that are here, they talked about really utilizing resources. I mean, this is really a strategic way of thinking. Like, honestly, you can vanish all of your resources. Like those from clinical background, they would love to live in a life like an ideal scenario, but this ideal scenario is not existing. And they made a beautiful comparison between North America and Africa. Co-mobilism in Africa is existing in North America, in spite of the gap in resources. So Abdurrahman is really important for me. We would really thank you so much, Wallahi, for. I would like to thank our speakers. I would like to thank the audience. It's a great honor for me, honestly, to present such speakers. Thank you so much.
يعطيكم العافية. نرحب بالدكتور حكيم الحكيم عضو اللجنة العلمية لتكريم المتحدثين. دكتور عبد الله الهيفاني. دكتورة بشاير الصوينة. دكتورة عائشة بدر. يعطيكم العافية.
First of all, I would like to thank the organizing committee of this wonderful conference, especially Dr. Abdurrahman Al-Swadi, for inviting me and giving me the opportunity to be one of the moderators at this conference. It's my pleasure to introduce myself. My name is Nada Al-Asari. I'm the supervisor of the Compounded Tier and Product Preparation Services at King Abdulaziz University Hospital, Jeddah. Dear colleague, we conclude this wonderful conference by this last session, which is talking about the necessity of adding the premixed formula of the parenteral nutrition to the hospital formularies. Now we are pleased to welcome the first speaker in our session, Dr. Hakim Abdulaziz Hakim. Dr. Hakim is one of the leading clinical pharmacists in surgery section at King Faisal Specialist Hospital and Research Center in Riyadh. He is also an adjunct assistant professor, clinical professor in College of the Medicine at Al Faisal University. Dr. Hakim also certified as a pharmacotherapy certified in the board, certified in the pharmacotherapy. Dr. Hakim will discuss today an exciting subject about the premix parenteral nutrition and evolutionary concept in nutrition support. With that, I ask that you give your full attention to Dr. Hakim and join me in welcoming Dr. Hakim.
Thank you very much, Dr. Asadi, for this introduction. And before I start, I would like to thank all the organizers over here at the IHO. We really enjoyed this moment from its beginning till the last session with this very interactive, nice session like we had with diabetes management. Today, I see also Dr. Saad Tawil, okay, maybe far way older than I should be, okay, this, she's my colleague and we're going to start this session. I hope it would be like a sort of debate session, this, because we are pro compounded parental nutrition, and we are using the dual, two types of the nutrition support when we give parentally. So I'm going to talk about the premix therapy and focusing on it. Now, and unfortunately, because before I start, I would like to disclose that I don't have any type of conflict of interest, whether if it's financial or even those non-financial type of conflicts. It's not working. Okay, let me start with just some definitions of the parental nutrition. The problem that not all our universities and our college of pharmacists, unfortunately, there's a focused or concentrated material for parental nutrition. Unfortunately, though most of our hospitals, we carry the TPNs, the fields and how it was labeled. Now, just simply, it is for our students who I believe that many of them are joining us here, thankfully. It is the process of delivering the nutrients, whether it's micronutrients, we're talking about dextrose, amino acids, and lipids, together with some sort of micronutrients, including vitamins and trace elements. And those are delivered through intravenous route. It's a life-saving formula, so it's not less than any other medication that we consider as a life-saving medication. When we deliver this type of nutrition solely, then we call it TPN. Recently, the ESPI, which is the European Society concerned with parental nutrition and enteral feeding, and the aspirin, both of them, they recommended to move away from using the term of TPN. That's because we don't want to give the inference, the definition that you might deliver all the nutrients from one solo route, which is the intravenous. If you could use the oral form, or you can use the enteral feeding, then please go ahead and use it even at partial amounts. Now, when Rhodes introduced the PN, even those who are interested to look at the TPN literature, you're going to find this terminology, which is hyperalimentation. They propose that you can push massive amount of nutrients to the patients with this route like that does get affected by statin. The aspirin. It's not very recently, by the way, it's more than 10 years ago, they considered the TPN among the high alert medications. Now, oops. I should be gentle on that. Okay, there's a slide missing, I believe. Okay, it doesn't matter. It was introductory road of how the TPN evolved. Just part of the history of the PN. It is considered when the surgeons, when they look to their paradigm and what they introduced to the medical field, PN ranked number 4 among those innovations introduced to the medical field. Together, can you believe it? Whether it's with solid organ transplantation, vascular surgeries, and even minimally invasive surgeries. Okay, now we have the standardized type of PN. We have the premixed TPN. Now it comes in two different forms. The first one, it comes at many hospitals. They formulate, they compound TPN, but it's not theoretical fashion. Their pharmacies, they will compound a mixed formula in a certain amount of amino acids, dextrose, and lipid. And this standard formula will be distributed to the wards, and the clinicians will start to manage the requirements according to the patient requirements by changing the rate of the fusate. The other form, that's the new thing, that's what we call the commercial premixed PN formulas. We have 2 types. The first one, it consists of 2 chambers, including the amino acids. The other chamber include dextrose, while the third a multi-chamber formula containing lipids in addition to dextrose and amino acids. Okay, now most of the literature that's enriching the premixed PN comes from Europe. In a survey that was conducted in the south of the millennium, in a country like Switzerland, that's more than 70% of the clinicians they were using the premixed TPN at that time. In France, almost more than 1/3 of the patients they were receiving premixed PN when there is a requirement to supply the patient with nutrients parenterally. In Belgium, it was a bit lower at 14%. Now, when we look at the premixed TPN, the good thing, even for us as a pharmacist, we're engaging in the process of compounding this complex formula. It's very simple. Just bring the PN back, squeeze it, apply some pressure on it, and automatically the separating sheet will be broken, and you're gonna get a homogeneous mixture. That is really, this could be, in our Arabic traditions, we say that's Galileo or a shade. So opening a premixed PN is far easier than you're gonna fry some eggs. Now, what provoked the hospitals to seek other new formulas was the JSA, which is the Joint Commission that most of our hospitals nowadays are cleared by this organization. In 2004, the Joint Commission, they recommend that the drug concentrations available in hospitals need to be standardized. And that recommendation made some shock to the pharmacists at that time, because PN is a complex compound, and whether if we're going to meet the GCI requirements, then how are we going to deal with the PN? So that opened the eyes, and even from the other side, from the Atlantic towards Europe, and how we are practicing, how they're supplying their patients with nutrition, then that attracted attention to the premixed. And there's a big problem now. Now, in the United States, many of the pharmacists, they are depending on their sellers, and they're specialized pharmacists in TPN. Now, with this premix, will threaten their job, and they will threaten their work. Here was the problem. So the Aspen at that time interfered, because it really was something threatening the career of the pharmacists working in TPN. And they formed this task force that reviewed the evidence about the supplying of the TPN to the patients. And in 2007, they came with a soft recommendation. This recommendation showed that multi-component solution like PM, some PM bags, believe it or not, contain more than 35 different molecules. So PN was considered as a more complex drug solution. So in another way, that PN could be waived from the standardization process that is required by the Joint Commission. Now, what's the advantages of the premix PN? First, there's a potential reduction of error during the preparation, during the administration, and I believe that even in the kingdom, we have some hospitals. They are when there's a patient requiring nutrition support, some clinicians they order dextrose to run alone in one line. The other line will be occupied by amino acids, and the third line will be, you're going to see it running a lipid running together, and all of them they're joining at one Y side. This is a real problem, and there's a potential of errors. It would be very high. Now, also the incidence of infection, that it has been shown by good evidence that the use of the premix PN will reduce the incidence of Lyme infections. Besides, shelf stable. So you could keep 4 boxes, 24 PM bags, 50, more than that, in a shelf within the pharmacy, and that will overcome the problem of expiring premix, the compounded TPN, which is almost stable for, I believe it's 48 hours is the max for the compounded TPN. Most of it now in the south region of the kingdom, where for the winter campaigns, most of the patients they're receiving the premix TPN. Now, one study assessed the incidence of error that could develop when using intravenously compounded formulas. They found that 37% of the error developed from PN, from a compounded, manual compounded TPNs, while 22% of the errors come from PNs that totally dependent on its compounding on machines. And this study was conducted in 5 hospitals in the United States. Okay, so I think we don't overestimate the incidence of Lyme infections, but it is one of the mortal infections that could task the patient's life during admission to hospital. Now, the thing that if you have a patient who had a PICC line, or let's say, or any type of central line, and this line is running through it chemotherapy or other forms of medications, and the other patients they had PICC line or Portacat or any other central line, and those patients were receiving a TPN through their central lines, the incidence of infections is significantly higher than patients with lines, central lines without PN running. The only one prospective study that's reminded Dr. Demirtas today in the morning. He was talking about the interest, he only found one randomized trial in his presentation, but he was more fortunate than me because the trial he presented was published in New England Journal of Medicine. This study was not. So, I mean, that's the level of evidence we have in our hands to assess the premix PN. However, the outcomes of this study that assessed, it's a multi-center prospective study that assessed the incidence of infections on patients receiving compounded TPN versus the premix TPN. And the incidence was, there was significant difference in the patients who received development of Lyme infections and those who received the premix type of PN compared to the compounded TPN. The ASHP and the US pharmacopoeias, they classified the the compounded TPN as a medium to high risk for contamination with microbial. It's very logical. It's not something surprising because it is manually prepared and it needs to be added the formulas one by one. While those compound premix PN, they are considered as a low risk for microbial contamination. Okay, so in Alabama in 2011, and that provoked really the FDA to really look further in the premix PN. In Alabama, there was an incident that happened in year 2011. There was contamination of the TPNs in 19 admixture from one single pharmacy, from one hospital. And unfortunately, this incident tasked the life of 9 patients. So that really, it was a really shocking incident that shocked the whole states from the east to the west. Now, there's a problem, you know, and most of you, especially those practicing pharmacists, they being disgust and the aseptic techniques, and they started to give injecting the PN. And even if we have this totally running compounding machines, you still, the pharmacists need to hang, or the departments need to hang the bags, to change the line time by time, and recalibrate the machine. And all of this might carry risk of contamination. Now the cost. I believe Dr. Mohammed will be now also happy as well, as soon as he's handling the Ministry of Health costs now, other medication-related costs. Now, there's been good evidence showing that using the premix TPN is associated with decreased risk, decreased amount of cost required, or expenses required to be paid for it from the institutions. Now, this is a systematic review that assesses the cost of the compounded PNs versus the premix PNs, including those, if you are making the TPNs from outside, that's by contract from a center that they synthesize their compounded TPN and bring it, deliver it back to the hospitals. They were included in this systematic review, by the way. And there's 5 studies showing that all of them, they showed that the multi-chamber compounded premix PN surpasses the cost for, they had a lower cost compared to the compounded PN. Now, however, when we look to this systematic review, we need to pay some attention. We need to look at it more carefully. The problem is that they include some centers. They are very primitive in their support their TPN. As I said, using the dextrose alone, protein alone, and lipids alone, and the nurse will be responsible to hook all of these compounds with all of the risk of error and contamination. And they were included, by the way, in this systematic review. And the hospital pharmacy compounding, whether it's all-in-one or they're using the North American fashion PN, which is the 2-in-1 TPN, or even the outsourced TPN, they also were included in this systematic review. So we're talking about a really wide spectrum of TPN formulas. They're making the extracting a conclusion a bit difficult. We need to also look to the pricing. The price that one study conducted by King Faisal Hospital, I assure you that the price we are getting is different from a hospital or a secondary hospital at a different place. And even by time, the companies still tend to decrease lowering their price year after year. For example, we had smofcarbidin in 2011, I believe, or 12, in King Faisal. The bag at that time was more than 500 Saudi riyals. Nowadays, it's less than 300 Saudi riyals. And now we're hosting different formula, by the way. Also, you need it's one of the important things, and that the using the premix TPN will never, ever eliminate the role of the pharmacist. Now, why? Because you need expertise to handle this premix TPN. You need many of these patients, because this is a premix formula, you need to add, you need to run electrolytes with it. Even in my vision, the TPN pharmacists who are working with the premix TPN need more expertise in dealing with electrolytes, because these electrolytes need to be given concurrently as a boluses or embedded within the IV fluid, which is making the total fluid intake for the patient. Now, the electrolyte irregularity, this is one of the major drawbacks of using the premix, by the way, which is that in a study compared the 2-in-1 premix PN versus the compounded PN, it was a single study retrospective in its design, and they showed that although most of the patients in the compounded TPN and the patient in the premix TPN, they achieved the protein goal. However, there was a higher amount or a higher need for electrolyte correction, or because there's irregularity. Most of the irregularities were in the hypofashion, hypokalemia, hypophosphatemia, and etc. And the majority of the electrolyte disturbances were observed with the sodium electrolyte. So how is our experience in King Faisal? How we are dealing with the premix TPN? We had olecfinomil, that's one with my mentor, Dr. Hamdi Amin. It's a good time to appreciate him for all of what he delivered to the TPN paradigm in Saudi Arabia. The whole kingdom really benefit from this gentleman. Then we moved to snuff-carbidopa. Then recently, just 2 years back, we added the Olimel N9 electrolytes. And the most really factor that played a role in selecting the last formula is the price. The price played a major role in selecting the premix TPN to be added to the formulary. Now, this sheet we designed, and that's what we are working on a daily basis. That's how we run our TPN. We had a fixed rate, 40 mLs by an increment of 5 until we reach 80 mLs per hour. Then if you're going to pump the whole bag to the patient, which is it is a 2-liter bag, then we might unfortunately go to 83.3. We don't like to use the incremental other than the 5, the multiples of 5, because just to make it easy for the nurses and for the pharmacists when we can calculate the amount of coverage required. Now, because there's really, the literature is very spare. There's no, if you're going to look to for any prospective studies to assess how you're going to manage the electrolytes, there's none. Really, there's some small retrospective studies. So we took now this initiative and we started with us this month. We had the acceptance. Thank you very much, Dr. Aziza, for your support. She's handling the pharmacy research committee. We got the approval from the pharmacy, fortunately, and then we got the ethical committee approval. And it will be a multi-center trial, King Faisal Hospital and King Fahd Medical City with Dr. Noor over there. And we just registered the study at the clinicaltrial.gov. We are welcoming any center from in the kingdom, any center here. If you're going to help us with 10 patients, we might include you in this prospective cohort study, which will be started this month. We suspect we're going to get our outcomes after 5 months. But please, any center, even if you can give us 10 patients, those will be more than sufficient for us to be part of this research.
Excuse me.
Okay, okay. So the problem with the drawbacks also of the PN, that's one size will not fit all. Yes. So obese patients, they're not candidate for this premix PN. You cannot just decrease the lipids and get higher dextrose, for example, or decrease the protein. Patients with diabetes mellitus has been shown that TPN in ICUs, patients who develop hyperglycemia with TPN, that would increase the mortality of the patients. So really, we need to be cautious when we deal with the components of the PN. Extremely underweight patients, also we need to take over caution and preferably not to be using the premix TPN, and fluid restricted patients like patients with heart failure or patients with renal impairment. So we're talking a wide spectrum of patients that we cannot use within premix PN. So that will be might act as an assurance for those advocates for the compounded TPN. So in conclusion, premix PN can be used as a primary and alternative formula for nutritional support for a wide range of adult patients. Premix PN offers a convenient and shelf-stable option. Most of the studies that support the premix PN are retrospective, unfortunately, and the premix PN use is associated with reduction in the bloodstream infection. That's one of the almost major advantage of the premix PN. And in my opinion, that hospitals need to maintain both formulas. The premix PN and also the compounded PN need to be maintained in all the hospital formulas. Thank you very much for your attention, and for Dr. Asla to follow up with her vision, just with or against.
Actually, you summarized so many points which become unanswered for the parental nutrition. Kindly, audience, we will leave the question at the end, and it will be held at the discussion portion of the session. Now, we will move to our next speaker, Dr. Isra Atweel. Dr. Atweel is a consultant clinical pharmacist in intensive care, and she is the parental, she consultant clinical pharmacist in intensive care unit and the parental nutrition. She's coordinator at King Saud University Medical City. She earned her master's degree from King Saud University and her specialized residency from Saudi Commission for Health Specialties. Dr. Atweel is board certified in pharmacotherapy, nutrition support, and critical care. Her main area of interest and practice are nutrition support, critical care, formulary management, and clinical research. And today she will be sharing with us her expert opinion on the customized parental nutrition service in hospital pharmacy. Is it luxury or necessity? Please join me in welcoming Dr. Atweel.
Assalamu alaikum wa rahmatullah. First of all, thanks for the invitation for such a great event. This is Isra Atweel. Today I'm gonna talk about the customized parental nutrition service at the hospital. Actually, my talk will not contradict Dr. Hakim's one. I agree with his thought and opinion. I will add additional points in order to solve this conflict, misunderstandable conflict. I'm working in King Saud University Medical City, which composed of different centers and hospitals, mainly at KKUH, King Khalid University Hospital. We are honored to have one of the huge bariatric centers in the kingdom, and we own the Center of Excellence. We are dealing with about 40 to 50 bariatric surgery cases per week. Very difficult. Okay. Okay. I declare any financial interest, and so going to the parental nutrition formulation, it can be customized, meaning that tailored to specific patient population. And the other type is the premix, as Dr. Hakim talked about it in details. So what are the, some of the slides, by the way, missed. Okay, so there are different terminologies for the customized parenteral nutrition. You may find it in the literature. For the customized, we can refer it as hospital compounded, tailored, individualized, or personalized, and I will abbreviate it by CPNS during my talk. And the other part is the premix, PPNS. So what are the advantage of using the customized parenteral nutrition? The advantage of the customized is the disadvantage of the premix and vice versa. So the customized, you can tailor it according to your patient population. We have many patients with comorbidities and fluid restriction, so it mandates the use of the customized parenteral nutrition, like the patient with renal failure, obese patient who require permissive underfeeding or low caloric intake, high protein diet, neonates and pedia. So premixed cannot fully replace the customized. While what are the disadvantages of the customized? Of course, I'm not biased to one of them. Cost, I'm not referring to the direct acquisition cost, it's the total cost of the manipulation itself, the manpower, the staffing, and the safety issue. It's a complicated process. We are dealing with more than 30 to 35 ingredients, so the prone to the error and during the compounding will be higher. Microbiological contamination, yes, maybe. It's time consuming, it's a complicated process, and of course, all of you will agree with me with the shortage of resources. Who doesn't have a shortage of potassium acetate, potassium phosphate, zinc, and the multivitamins? Shelf life, if you didn't add the multivitamin and trace element, you can keep it in the refrigerator for 14 days, while the premix, you can keep it outside. Weekend issue, you have to come in the weekend to prescribe the customized if there is a new start, although it's not urged to start, of course, for the adult, they can be kept MPO for 5 days, but again, it's headache. And for home parenteral nutrition patient, the premix is an option for them. So I will go through several studies. Actually, most of the studies were retrospective with poor methodological and study design, but they found that the customized and the premixed parenteral nutrition are comparable in the nutrition efficacy and caloric intake. Why? The customized has higher protein intake, and the patients who received the customized, understandably, they were sicker. Yes, because you have to tailor your amount or your formula according to your patient population. So, statistically significant greater patients receiving the customized were ICU, Crohn's disease, cancer patients with several comorbidities. In addition, the premixed were associated with modest, although statistically significant, reduction in the length of hospitalization. I think this is due to the patient characteristics themselves, not due to the formula itself. And the frequency of electrolyte abnormalities, actually that had been discussed with Dr. Hakim, was higher in the premixed group, mainly the sodium. These are the studies that, it's only a screenshot of them, that discuss the clinical efficacy of premix compared to customized. Some of them they found the multi-chamber premix advantageous and some of them not. I chose this study which compared the customized versus the premixed in non-ICU patients. It's actually a retrospective study that included the patient who received parenteral nutrition in the last year. They excluded 112 patients and only 97 patients included in the comparison. This is the demographic of the patient. The mean age is 60 years, and most of them were in the normal body mass index, and 78% they underwent several kind of surgeries, including mostly the bowel resection and pancreatic surgery. What they found that the amount of lipid in the standardized premixed was statistically significant, higher than the customized, while the amino acid and dextrose amount in the customized was statistically significant, higher in the customized. The same for the sodium and the potassium, as opposite to the magnesium, which was higher in the premixed. But they conclude that in order to ensure appropriate prescribing pattern, you have to make like a careful decision on which formulation you're going to choose according to the indications and contraindications. Actually, one of the arguments that has been promoted by the manufacturer or the company, that if you are using the premixed, you will be able to have the first bag much quickly than the customized. And in my opinion, I think sometimes if you start the parenteral nutrition quickly, you will predispose the patient to higher risk of hyperglycemia and electrolyte abnormalities. Safety issue. Most of the studies, they found that the risk of the bloodstream infection was 30% higher in patients receiving the customized parenteral nutrition. And this study, it was like a retrospective study, included 44,000 patients, and the majority of them, 41,000 patients, they received the customized, and only 3,000 patients received the premixed. And they decided that the risk of bloodstream infection was higher in the customized parenteral nutrition. So our reference here is the American Society of Parenteral Nutrition. Going back to the 2007 position paper that surprised all, as Dr. Hakim said, that in order to ensure the appropriate prescribing, you have to emphasize more in the standardization. And the standardization process that they are referring to, it's in the ordering process, in the labeling, in the screening, etc. It's not only the using of premixed solution. So standardization process may or may not include the use of premixed parenteral nutrition. Okay. So all of I said before, it's the theoretical part. So what about the clinical part? What is the current scenario or situation? In our hospital, we are dealing with around 30 to 35 parenteral nutrition orders daily between pediatric, neonates, and adults. And the adult patients, around 12 to 14 parenteral, sometimes 15 parenteral nutrition orders. Most of them are bariatric patients, post-bariatric surgery, or cancer patients in the ICU. So you have all the time to tailor the needs or the available formulation according to your patient population. There was a concern of switching to commercial premix, which I don't agree with, that the pharmacist and the technician working in the area, they will use their expertise. And the customized is well integrated in most of the hospital delivery system. Yes, I agree with that point. If you are dealing with the majority of patients who require the customized and only maybe 1 or 2 patients per week, they will fit the premix. So in this case, I wouldn't frame the or incorporate the premix into my hospital formulary. This is just a decision chart. It's multiple questions. If you're going to answer them with yes or no, you will end by helping you to choose whether the premix versus customized. This is the real scenario that I'm facing on my daily basis. This is one of the patients post-laparoscopic sleeve gastrectomy with leak who require to be NPO for at least 2 weeks and will start for him parenteral nutrition. This is the formula that prescribed by the clinical pharmacist. And if I'm gonna use if you can see here that I'm giving him a huge amount of fluid, hypocaloric formula and high protein with a huge sodium requirement. So if I'm gonna pick one of the formulas from the premix, I would choose the 2460 ml. But again, here the dextrose amount is 313 milligram, which is double the amount of the needed by the patient. The cost here, our acquisition cost in our hospital, 108 riyal for this, and the cost for this bag is 265 riyal. This is only the direct cost, by the way. The second case scenario, cancer patient admitted to the ICU with septic shock and developed acute kidney injury. So this is the proposed formula with fluid restriction, protein restriction, and electrolyte restriction. You may not even give electrolytes for him. Here is the premix formula. I'm going to choose the 1 liter formula. If you see here, the phosphate is nil in my formula, and here is the minimum of 12 millimoles. The cost will be 229 riyal for this formula, excluding, of course, the multivitamin and trace element, and here's 425 riyal. Okay, so I think this Dr. Hakim, he discussed the economic and ergonomic outcomes. Some of the studies, they found that the multi-chamber bag is more cost effective than the customized, and some of them, they have like a conventional favor, meaning that it's more cost effective based on the unit volume. If you have more than 15 parenteral nutrition per day, the customized will be cost effective. But for the smaller institution with parenteral nutrition preparation per day less than 10, some of the studies said, it will be, the premix will be much cost effective. So, as a summary, you have to consider your institution size, your personnel, your staff, the expertise and the available resources in your hospital, and the most important one, your patient population you are dealing with, before you choose whether the customized or the premixed. The premixed may offer the real advantage for the smaller institution with limited expertise and personnel or space for the compounding, or if the unit volume is less than 15 parenteral nutrition order per day. And we have to consider the available local Saudi FDA registered formula, because now we are stuck with the registered Saudi FDA formulas. We don't have the wide variety like in the US and Europe. And the final point, I will leave it for the discussion. Can premix parenteral nutrition fully replace the customized? And is really the customized something luxury or necessity for our hospital? Thank you all for listening. And I'm very excited for
Thanks for this fruitful and excellent presentation. I want now to invite the speakers to kindly Dr. Isra and Dr. Hakim, can you come please to the stage to receive the questions and inquiries? I'll open the floor for the questions. Does anybody have a question for the speakers? No question? Okay, تفضل.
Thank you very much for the great and informative presentations. And you are icons in the PM, parental nutrition, both of you, and the whole team. I just want to ask you something regarding the new needs, especially the new needs, because of the Ministry of Health, we have a lot of maternity hospitals, that we have a majority of our patients are, maybe we can say that new needs. Which one that you would prefer to use? The premixed or the tail?
For me, okay. For me, units, for me, they are periods. The last unit I dealt with I specialized here with TPN that was more than 10 years back. So, but let me make it very clear that nowadays the premix never been used, or even all the use of the premix is under trial. So I doubt it would be of benefits for this population of patients. Yes, maybe the first one.
For the neonate and some of the pediatric population, we don't prefer the premix at all. We may have a standard formula compounded by the hospital for the new starters. That's it.
Dr. Shinawi, now there is only one FDA approved, Saudi FDA approved formulas for term patients only. And as you know, the situation of the neonates are coming and knowing their situation is unstable, so we are not. But there is actually two formulas for starter TPN as per the company and for preterm, but until now it's not registered in the Saudi FDA.
Just only to add that in NIH recently, we stopped transferring from one institution to another. How we overcome this? We are utilizing the 3 approved Saudi FDA companies outsourcing the tailored TPN. The TPN will be delivered to your hospital, completely done by clinical coverage, pharmacy coverage, and preparation and materials, and the delivery, even with the accessory, even with a much less cost than it was the direct cost that it was presented. So I believe that the outsourcing in the whole kingdom, it's if you visited, I'm not advertising for the 3 companies, by the way, but we are very proud to have them. If you visited those companies, you will find that this is a state-of-art, highly excellent places to prepare the TPN, or the parenteral nutrition only. And they provide you with the clinical pharmacy services, with everything, even with the delivery. So it is good. We stopped the transfer from one hospital to another hospital just only because that the patient require a TPN. And we make that this has to be contracted. Even if you cannot prepare the TPN in your institution, you can borrow it from the nearby hospital. Or if you cannot borrow it from the nearby hospital, you should find a way to purchase it or to contract with one of the 3 approved companies to bring it to your hospital. So the TPN, actually, the service is expanding and expanding. It's not just only limited to hospitals, that you have to bring a lot of materials, robots, manpower, and specialized people. Now I believe that the pharmacy career is expanded to more outsourced than to have it in the same hospital.
Okay, Dr. Mohammed, if you could just allow me, please. Regarding the outsource, now, in my slides, I remember one of the slides shown with the incident that happened in Alabama. It was only for 9 patients in a population that is 10 times the Saudi population. Now, I have some concerns about the outsourcing. You're going to tackle it from different point of views. Now, the first thing about the training. Now, we get our students from the colleges to be exposed to the PN preparation and how to write the formulas and the clinical aspects of the PN. Now, transferring this to a company, I don't know how it would be feasible, and even the space for the students over there at that company. That's number one. Secondly, now the contamination over there. Now, let me bring back the chlorinated incident that happened two years back. Now, this is a local formula that was approved by the Saudi FDA. It was cleared, and even most of the hospitals, they were, I don't want to say they were forced to take it from this company because it's a local to support the local manufacturing. Unfortunately, we ended with patients who had CAP and they died from the insufficient chlorinated. Now, the problem here with the TPN, now how are we going to assure that, is there any quality assurance process by the Ministry of Health on these companies to follow up the contamination? Let me say that it's in the delivery process, that's, let me say that the car was stopped by enemy because in the heavy traffic, I mean, like in cities like Riyadh or Jeddah, the driver will stay for more than 2 hours. Would that affect the stability of the phone?
Yes.
All of this question may be directed to the Minister of Health.
Therefore, I'm telling you, this is after I visited them. And we made sure that everything will be tracked, especially with the temperature log. It will be tracked and it will be electronically monitored, for example, the stability from the time that it will leave the institution until the time it will reach the patient, or it will reach the peripheral hospital in the region. So it will be totally monitored. Regarding the space for the students, they have a very huge place that they can be trained on. Believe me, it's bigger than any IV room I've seen in the whole hospitals. Very big area, and the area is absolutely matching the whole 797 criteria. And the pharmacists that they are working there, they are our colleagues. They are highly expert in preparation. TPN, one of the companies, and not again advertising to them, but Dr. Hamdi Amin, he's the one leading the clinical staff in that company. Dr. Hamdi Amin, as you mentioned, he's one of the icons in the TPN in the whole kingdom. So regarding the quality, of course, definitely, it's like any company that it can have some defects, some problems in order to modify, to improve again and again. However, having those companies, it's an add-on to us. It's not just only the tailored in your hospital, not just only the pre-mixed, but I believe that we should add, whenever it happened in the US, the outbreak for the TPN, when they were outsourced, we did not close the outsource. It's still open, but they made more restriction, more standards that they have to follow in order to have this. So we are again, we are in favor, in first of all, in the preparation tailored TPN in your hospital, and the second thing in the pre-mixed TPN. However, that we are facing a lack of experts in the MOH for the TPN. We don't have those people. Again, as I said it many times, the number of clinical pharmacists in King Faisal Specialist Hospital, they are more than the number of clinical pharmacists in the whole Ministry of Health. So we lack, we need this expert people in our institutions. So that was a light for us. We do not want to transfer for King Faisal for just only having the patient for TPN. We do not want to transfer it to King Khalid University Hospital. So that was actually as a help for us in order to provide the TPN, especially for our neonates. We have a lot of maternity and delivery hospitals. So those patients are transferred to a specialized hospital just only to take TPN. It's unfair. So if we can provide a TPN in their hospitals, it will really help the patient, the family, the referred hospital. So you will save a bed in the specialized hospital. This is the reason why we went for this. So I agree with you totally, 100%. However, this is maybe a specialized case for us in the ministry.
If you allow me, Dr. Shinawi.
100%. However, this is maybe a specialized case for us in the ministry.
If you allow me, Dr. Shinawi. Actually, I visited one of these two out of these outsourcing company, and I agree with your opinion. But my point is how they are prescribing the order. They are looking to numbers. They are not seeing the patients. They are not discussing the case with the healthcare provider. Sometimes even giving sodium for patients with unknown cause of hyponatremia is dangerous. This is my only point for not dealing with the outsourcing.
Okay. Any other questions, please? Dr. Isra and Dr. Hakim, I have a question for you. As you know, there is many retrospective studies about comparing the compounded parenteral nutrition and remixed parenteral nutrition. Do you think the presence of the pre-mixed different formulas in the hospital is necessity, or we can keep these formulas for some patients and provide it for the home healthcare patients and stable patients?
Yeah, as I said, from my opinion, that keeping the customized, the hospital compounded, okay, this is the default. Some patients, yeah, they are stable, like the post-surgery, some kinds of surgery. The home parenteral nutrition is a very good option for them, but depends on how many patients you are dealing with. I remember something Faisal, especially in hospital, maybe the number now increased. We have like at least 6 to 8 patients receiving the pre-mixed, and they fit the criteria of starting the pre-mixed. In my hospital, when I try to look how many patients I can shift them to pre-mixed, maybe it's done 2 patients per week. So this is why this one was one of the reasons I didn't extra.
Any other question? Okay, I close this session. Thanks, Dr. Hakim.
Small comment about the terminology of stable patients in the TPN paradigm is not well defined. Many times I hear from my colleagues who are covering the TPN, thank you very much for them even during the weekends, actually they are covering our patients. They label sometimes surgical patients as stable, while most of the pre-mixed literature came from patients who were visiting the ICU. So this is controversial.
They are fluctuating. Okay, I close this session. Thanks again, Dr. Isra and Dr. Hakim, for your nice presentation. Thanks, you audience. I know you are waiting for the result of the competition.
دكتور محمد السناوي تفضل تكريم المتحدثين. دكتورة ندى عسل. دكتور حكيم الحكيم. دكتورة إسراء الطويل. يعطيكم العافية. نسمع كثير انه في الجيس جديدة سواء في اي مرض كان، يمكن من اهمها الفترة الحالية اللي هو الدايابيتس. فسنوفي مع الدكتور سامي عبد السلام راح يعطونا نيو سوليوشن للدايابيتس. دكتور.
First, I would like to thank you all for attendance and Dr. Mohammed Shinawi and Dr. Badr Hawzi for the opportunity to be with you today in I Hope 2020. So I will start with the atopic dermatitis, and it is clear now that there is underlying Next slide. So it is clear that there is underlying chronic inflammation, mainly mediated by type 2 inflammation, and with a major role for IL-6, IL-14, 4 and 15, that is responsible for the main clinical picture of atopic dermatitis. So clinically, the patient is suffering from cracking, drying, peeling, and oozing and bleeding. And you notice that the patient with moderate and severe atopic dermatitis, there is around more than 50% of the body surface area is affected. And for those patients, there is around 90% suffering from dry skin 3 days out of 7, and 50% are suffering from bleeding. The current treatment option is very limited, starting with medium or mild cases, skin emolium, and then moving to corticosteroid. For severe cases, still there is limited option, and it is mainly cyclosporin and systemic immunosuppressant and phototherapy. The main limitation in this immunosuppression is that it is off-label use, broad-spectrum immunosuppression, and there is clinical and laboratory needs to monitor. Of course, systemic corticosteroids, you know the complication and the associated side effects. So dupilumab is selectively inhibit IL-4 and IL-16 that block the underlying chronic inflammation. There is a huge clinical trials, including phase 3 trial for patients either compared with placebo or topical corticosteroids, or even patients retreated with immunosuppressants. From clinical perspective, you can see the improvement of the eczema area score with around 40% after 1 year in Crohn's study. Again, pruritus is the main burden for patient perspective, and there is significant reduction and improvement of pruritus around 75%, and the number of patients who are suffering from disturbed sleep dropped from 43 to 17%. Again, there is a depression and an anxiety input or suffering from patient perspective, and in our clinical trial, either between 16 weeks or for 52 weeks, there is significant improvement in anxiety score and in the patient suffering from impaired sleep. Again, from safety perspective, we need to highlight that dupilumab doesn't need any clinical or laboratory monitoring, and only we have injection site reactions and conjunctivitis. So it has been included in 2018 guidelines as the management of severe cases, and it is approved already in Saudi. From cost effectiveness perspective, it was also approved by NICE for selected patient populations that it has been also applied in Saudi, who patients are already passed by one systemic therapy, and there is control for their mistakes. I will go for diabetes, and as you know, still in management of diabetes, there is unmet medical need, mainly driven by the fear of hypoglycemia, the risk of weight gain, treatment complexity, and the difficulty to control both fasting and post-plan. From patient and healthcare professional perspective, still fear of hypoglycemia with 74% is the main driver for this limitation of insulinization. And from patient and healthcare professional perspective, weight gain is still the main concern. So the concept regarding this complementary action between basal insulin and GLP-1 has been raised because it will complement the management of diabetes with two potent agents in management of diabetes. So GLP-1 will be specifically targeting postprandial, while basal insulin is mainly control the fasting glucose. So which GLP-1 we need to combine with basal insulin, or namely insulin glargine, in this comparison between lixisenatide and liraglutide, it's clear that lixisenatide has major effect on postprandial glucose. This is confirmed also by another trial showing the significant reduction of postprandial blood glucose compared with other GLP-1. In our trials, Lixilan-L comparing I-glargine Lixi or Soliqua plus metformin versus glargine plus metformin, it was equally distributing the patient population with BMI around 61 and A1C more than 8. So from A1C reduction, Soliqua achieved 1.1 reduction of A1C compared to 4.6. And the higher patient population achieved this goal either less than 7 or less than 6.5. So around 55% achieved A1C level less than 7 and 34% achieved less than 6.5. Another endpoint was the level of fasting and postprandial blood glucose. So it is here 2 hours postprandial was significantly reduced with I-glargine Lixi, including weight reduction with 0.7 compared with increase with glargine by 0.7. Again, with clear hypoglycemic benefit, it is lower with I-glargine Lixi compared with glargine. Also, they tried to control or to see the impact of Soliqua on different meals. So they tracked the glucose level after each meal, and you can see that either after breakfast or lunch or dinner, there is significant reduction of postprandial blood glucose with Soliqua compared with glargine. In another trial, trying to compare the I-glargine Lixi with the basal bolus or basal plus regimen as an intensification regimen commonly used in diabetes management, they found that I-glargine Lixi or Soliqua is achieving the same A1C level reduction with the basal bolus or basal plus, while there is a clear weight benefit for Soliqua. Again, with confirmed low risk of hypoglycemia, reaching to 0% for severe hypoglycemia. They also tried to cross-match patient population in 2 different trials between Lixilan trial and Goal trial, trying to indirectly comparing the impact for both A1C level and hypoglycemia. The patients were equally distributed for the 2 arms, including the A1C, the duration of diabetes, and BMI. And the result showing that I-glargine Lixi or Soliqua is achieving better glucose control with A1C reduction, while showing either individual or composite endpoint better than basal bolus. So from A1C reduction, more patients achieve the goal. From weight gain, there is weight benefit with Soliqua and with better hypoglycemic profile. And when combining 2 or 3 these endpoints, so you can see that around 27% of the patients achieve A1C level and less hypoglycemia and no weight gain, which is the ultimate goal for management of type 2 patients. You can see also here the significant reduction of weight gain compared with basal bolus regimen. And from hypoglycemia perspective, either with the definition of hypoglycemia at less than 70 or 54, there is significant reduction of hypoglycemia with Soliqua, reaching 66% for a strict hypoglycemic index. Soliqua has a very simple initiation regimen with the patient receiving 30 units to start with the same, and any patient has more than 30 units, will start with 30, and with simple titration, either 2 or 4 units when the patient is not achieving the fasting plasma glucose. It is better to mention that it is also coming with the common SoloStar pen, which is used for lungs, so the patient is used to use our pen. So finally, Soliqua achieved the complementary mechanism of action to achieve complementary control, favorable hypoglycemia, and weight benefit, and in the same time with very simple, well-tolerated regimen, once daily medication. Thank you.
السلام عليكم ورحمة الله وبركاته. أسعد الله مساءكم. المقدرين ما شاء الله الحضور الجميل في اليوم الأخير للمؤتمر، شكرا لكم فردا على تجاوبكم وحضوركم وتفاعلكم مع فعاليات المؤتمر. الآن احنا انتهى الجدول العلمي تماما. راح نبدأ في عندنا مسابقتين. راح نبدأ المسابقة الأولى اللي هي المسابقة الوطنية الأولى للتثقيف الدوائي، تقييمها الإدارة العامة للرعاية الصيدلية مصاحبة مع المؤتمر. قبل ما نبدأ المسابقة حابب إني أعلن عن الجوائز اللي راح تكون للفائزين في المسابقة. سوف تقدم الجمعية السعودية للتثقيف الدوائي، جمعية الدوائي طبعا كلكم عارفينها، جوائز للفائزين الثلاثة الأوائل في المسابقة: اشتراك في لكسيكون من البروفيشنال اللي هي الدرجة الثانية لمدة سنة كاملة، واشتراك مجاني في مبادرة التعليم الدوائي تبع جمعية الدوائي برضه لمدة سنة كاملة في أي منطقة في المملكة. بسم الله نبدأ المسابقة. الصيدلانية خلود حصيني هي اللي راح تدير المسابقة.